All right.
Okay. So good evening. Good evening, everyone. So today we continue with the curriculum topic on supraventricular tachycardia. Dr. Enajiro will be taking us on that. Over to you, Ma. Thank you.
All right. Good evening, everyone. So I'll be taking the topic supraventricular tachycardia today. And it will be based on the ESC guideline for management of supraventricular tachycardia. This is my outline. So the term SVT, which I'll be using in place of supraventricular tachycardia, is literally indicates tachycardia, atrial rate greater than 100 beats per minute at rest, mechanism of which involves the His bundle and above. Is used to describe all forms of tachycardia besides atrial fibrillation, which is very important in the ESC guideline, although colloquially, atrial fibrillation is known as an SVT, but according to the guidelines, it has now been described as a different form of supraventricular tachycardia, which is not added to the guideline, and VT. Usually requires atrial tissue or AV nodal tissue for initiation and maintenance. Expression is variable from asymptomatic or mild symptoms to severe symptoms. So the epidemiology, prevalence is 2.25 per 1,000, an incidence of 35 in about 100 per year. It's more common in women. Persons greater than 65 years, there's a 5-time greater risk than in younger people. Atrial fibrillation is the most common paroxysmal SVT, affecting about 3 million people in the US and about 0.4 to 1% population. So AVNRT is more common in middle age to older persons, while adolescents are more likely to have SVT with an ancestry pathway. So still on the epidemiology, atrial flutter happens in about 88 per 100,000 persons per year, with increased frequency in men and smokers and patients with a history of MI and heart failure. Then in women, there's an increased frequency of episodes which have been associated with monthly cycles and pregnancy. Prevalence of WPW, that's Wolff Parkinson White's pattern, is 0.15 to 0.25% and increases to 0.55 in the first degree relatives. So this is just to remind us about the conduction pathways of the heart. We can see the SA node, we can see the Bachmann fiber that connects the two atriums. We can see our internodal pathways. We can see it passing through our AV node, through our His fibers, which are divided into your right and left bundle. This is just a short reminder. So I'll be talking about just also a short reminder on the physiology of conduction, of cardiac conduction, which we all know that the SA node and the ventricular, we know that every cell in the heart can be used as the pacemaker of the heart, but the SA node, the way it functions is very different from the other myocytes, which we can see from the way it conducts its action potential. We can see from these two action potentials that there is one here, there's phase 1 here, there is no phase 1 here. There's a phase 2 here, and there's no phase 2 here. So if we're going to go through the depolarization of the SA node, we know that there's stage 4. So when you're looking at phase 4, we're looking at influx of your sodium. So it is described at this point that the SA node is never at resting potential. At some point, there's some leakage there's influx of your sodium into the cell in your phase 4. So it's never at resting potential, unlike your other myocytes. So when it gets to at least minus 40, we now see that the first calcium channels open. That's your T cells open, and it causes your calcium to enter into the cell. So we have your L-type and your T-type calcium channels. So it's the T that opens first at 40, then by 50, the T opens, then by 40, the L opens. That's when it now leads to this rapid depolarization, which is your 0. Then when we are talking about your 3, that's when it now shuts off and your potassium channels now open and there's an influx of potassium, which is very different from this. We can see that the starting of this also, like this and this, you can see that they're almost the same. Your 0 here and your 4 are almost the same here. This is also your sodium. There's influx of sodium here also, like this one, but when it reaches its action potential, what now happens is that your sodium now shuts off. Then your calcium channels now open up. Then by the time you get to phase 2, which your plateau phase, your calcium and your potassium channels are now open. Your calcium is now coming in and your potassium is going out before the calcium now shuts close. Then it's only your potassium that is open, which now leads down to your action potential. So this is a brief summary of the differences between your SA node and your myocytes. And I want to also mention in your SA node also, you have your IF current, which causes it not to actually have a resting potential also, which makes it very different from your baseline myocytes. So this is also a brief summary of your mechanisms of cardiac arrhythmias. We know that we have your MAT, you have your automaticity, which is divided into your altered normal automaticity and abnormal automaticity. You have your triggered activity, which is delayed after depolarization and your early after depolarization. Then you have your disorders of impulse conduction, which is your popular reentry, which you have your anatomical reentry and you have your functional reentry. So what is the clinical presentation of SVTs? You have to have a history. Sometimes you'll have palpitations, you'll have a history of syncope. You also, which is very important, you have to know the age of the patient. Like I mentioned before, people that have a history of smoking, people that have a history of pulmonary issues, you are thinking of atrial flutter. You're thinking of which one is more common in men, which one is more common in women, which makes sex very important, as I mentioned in the epidemiology. You're also thinking about the onset of symptoms also of the patient. So you know if there are other underlying etiological factors or electrolyte derangements, or even a history of MI that has led to the SVT. You also want to know the duration of the symptoms the patient is having. Also, that will also help with your diagnosis and how you want to manage the patient in terms of acute presentation and chronicity. They also want to know symptoms in terms of breathlessness, heart failure symptoms, because we know that there are some medications which you cannot use in a patient that has heart failure, especially your calcium channel blockers in patients that have structural, that's your dihydropyridine calcium channel, non-dihydropyridine calcium channel blockers. I think diazoxide that you can use in patients that have reduced ejection fraction. So you want to have that history in those patients, symptoms of heart failure. You want to also have you want to know that it's a recurrent SVT and can lead to tachycardia-induced cardiomyopathy, which is also a very important endpoint sometimes of some of these SVTs. So the most common symptoms is palpitation and dizziness. Other symptoms include chest tightness, shortness of breath, syncope, nausea, and phoresis. So I've mentioned all of this. So this is a summary from actually the actual guideline, the actual ESC guideline. How do you want to evaluate the patient? Like I mentioned before, you want to do a history, you want to do a proper physical examination to be able to know whether there's a background heart disease in the patient. You also want to do your baseline 12-lead ECG, rest ECG. You want to do your full blood count. You want to rule out things like anemia. You want to rule out things that could be a precipitant for the patient. You also want to do your biochemical profile. We also know that electrolyte derangements can be a cause of SVT or can trigger SVT, especially hypomagnesemia, which is also a known cause of MAT. You want to also do your thyroid function test also, which you know hyperthyroidism, even hypothyroidism is a cause of arrhythmias. ECG during the tachycardia, which is very important because some patients during outside the episode, their ECG is normal. You want to do your echo, obviously, to look for structural heart diseases. So other optional investigations you would like to do are your exercise tolerance testing, 24-hour ECG monitoring, telephonic monitoring, loop recorder, depending on the center that you're in, if they have these facilities, myocardial ischemia testing in patients with risk factors for coronary artery disease, and your EPS study. So this is the division according to the ESC guideline for your SVTs. You have your atrial tachycardias, which you have your sinus tachycardia, which can be divided into your physiological sinus tachycardia, inappropriate sinus tachycardia, sinus nodular reentry tachycardia, focal atrial tachycardia, multifocal atrial tachycardia. Then you have your what do you even call it again? That's where your atrial flutter enters. That's your multi-reentrant, macro-reentrant atrial tachycardia, which involves your carbo-tricuspid isthmus-dependent MRAT, which I'll be calling it that for now, from going on this presentation. And you have your typical atrial flutter, you have your counterclockwise I'll be talking about each of these individually shortly in this presentation. Then you have your non-carbotricuspid isthmus-dependent MR80. Then you also have your AV junctional tachycardias, which is the popularly known AVNRT, which is divided into the typical and the atypical. Then you have your non-reentrant junctional tachycardia. Then you also have your AVRT, which is your atrioventricular reentrant tachycardia, which can be divided into your autodromic and your antidromic. So, based on everything I have just said, now the baseline that you would like to do is to divide these patients, these tachycardias, into narrow, because their managements are very different. You want to divide them into narrow and wide complex tachycardias. So for your narrow complex tachycardias, we're talking about QRS complex less than 120, and these are the examples of those that are your narrow complex tachycardias, and they can be divided into your regular and your irregular. So the examples are seen here. Then you have your wide complex QRS greater than 120, and can also be divided into regular and irregular. This classification is very important in terms of when you see a patient, in terms of acute management of the patient and how you want to manage the patient, especially when the patient has hemodynamic compromise. So we'll start with your narrow complex tachycardia. So this is rapid activation of the ventricles via your His-Purkinje system, and this can also be present in high septal VTs. So narrow complex tachycardias also can be present in VT, and this is the form of VT you can present with, which will give you a narrow QRS complex. So this is the type of VT alone that can present with a narrow complex tachycardia. Presence of excitation on ECG with a history of palpitations will lead you to a diagnosis, obviously, of AVRT, which is usually, which can be your autodromic or antidromic. Sinus rhythm without pre-excitation does not exclude an accessory pathway, which I mentioned before. A patient can present and tell you the patient has a history of palpitations, but because the patient might actually have an accessory pathway, but at presentation, that accessory pathway is not manifest. I'll mention some examples. So there could be manifest accessory pathway. So because it's not manifest and it's latent during the time you see the patient might not have any pre-excitation on baseline ECG. Important factors to assess include initiation, regularity, morphology of both P wave and QRS complex in those patients. So this is an algorithm from the ESC guideline talking about how you want to assess your narrow QRS complex tachycardia patients. So we'll start from the top of the, sorry. Give me a minute, please. Let me try and get my, all right. So we can all put together. So we'd like to start from the top. So as I said before, narrow complex tachycardia is QRS complex less than 120 milliseconds. So is it regular? That's the first question you want to ask yourself. So I'm going to go for the regular route first before I go to the irregular route. So yes. So do you have visible P waves? If you have visible P wave, you say yes. Then you want to check for the atrial rate. Is it greater than the ventricular rate? If no, then you are thinking of your typical AVNRT, which I'll talk about what it means for a patient to have typical AVNRT, focal AT or JET, which is your junctional tachycardia or AVRT. So if you say yes, and the atrial rate is greater than the ventricular rate, you say yes, then that's most likely an atrial flutter, which we know that atrial flutter, P to P, most times is about 250 beats per minute. So if the atrial rate is more than the ventricular rate, I'm most likely thinking of the atrial flutter, focal atrial tachycardia, or even AVNRT. But that's rare even according to the guidelines. So if no, you're saying ventricular rate greater than ventricular rate is greater than the atrial rate, then yes, I think you'll be high septal VT, which I mentioned before, I think is even the only ventricular tachycardia that causes a narrow complex tachycardia. You're thinking of your junctional tachycardia or AVNRT, which is rare, or your nodal ventricular or fascicular nodal reentry. This is very rare, actually. I tried to read some literature on it, and there are very few studies on this. So that's what you'll be thinking about. Then if no, that means your ventricular rate is greater than your atrial rate. So you're thinking, so you now start considering your RP interval. So at this point, I want to pause. What is RP interval? When you look at an ECG and you're thinking of RP interval, you're starting from the R on the ECG to the P. So you're thinking about the duration in between the time that the ventricle has been depolarized to atrial depolarization. That's your R to P. So when you're thinking of an AVNRT, that's so you're thinking, so we're going to talk about AVNRT, but let me just explain it here a bit so that it will be easier so that we know why this classification makes sense. A typical AVNRT is a slow fast pathway. So that's what you're trying to say from an AVNRT, is that it takes the slow pathway first before it enters the fast pathway. So it takes the slow pathway from the atrium through the slow pathway into the ventricle. That's the slow pathway. Then its retrograde limb is now the fast pathway. Means that from ventricle to atrium is where it is fast. And that point is where you have your RP interval. So your RP represents the second limb, your retrograde limb of your AVNRT. So that being said, when you're talking about a short RP tachycardia, you're talking about a tachycardia that the depolarization from your ventricle back to your atrium is fast compared to that from your atrium to your ventricle. So from there, let's go down now. So they said short RP compared to PR. That's what I just mentioned. That's a short RP interval. So you have your typical AVNRT, which is a slow fast, So that makes sense. A focal atrial tachycardia too makes sense. But for your AVRT, it's very rare for that to be happening. It depends on the type of AVRT that you're having. So they said your RP is less than 90 milliseconds. Then you have another form also of RP greater than PR, which is greater than 90 milliseconds. Now, this makes sense for it to be your AVRT here. Then you have your atypical AVNRT. So your atypical AVNRT is a fast slow, unlike your typical that is a slow fast. So this is a fast slow. So it makes sense for this to be slightly higher than this because it's a fast slow. I hope I've not lost everyone here, but yeah. So we now have your long RP, long RP tachycardia, which includes your focal AT. So focal atrial tachycardia can present as your short RP and present as your long RP. Depends on where the focus of the tachycardia is coming from and what your AV node is doing at that point. So it depends. There are a lot of things that are involved. Knowing whether it's is a long RP tachycardia or a short RP tachycardia. AVRT typically presents as a longer RP tachycardia, and your atypical AVNRT also presents as a longer RP tachycardia. So these are examples. I'm not going to stay too long here. These are examples of ECGs that show. So the first one shows, so you can see this is a mat. This is ECG of a mat. So you can see P waves, varying types of, varying morphologies of P waves here. So this is an example of a mat. I'm going to drop the slides for everybody to see because we have so many slides. So I'm going to go straight to acute management in the absence of established diagnosis of narrow QRS tachycardia. So this is the illustration according to the guideline. How do you want to manage these patients? You want to find out, are they hemodynamically unstable or are they stable? If they are unstable, you want to do a synchronized cardioversion for them, which is a 1B recommendation. If they are not unstable, that means they are stable, you want to do vagal maneuvers for them. So in these vagal maneuvers for them, you want to activate acetylcholine, you want to slow down the heart rates by inadvertently slowing down the AV node in this patient. So there are many vagal maneuvers you can do. So you can do your carotid massage in these patients, but there are some contraindications to carotid massage. You have to find out if the patient has a history of stroke or TIA, or a carotid bruise, so you don't go in there and massage and cause a stroke in the patient by using force to release a plaque into the patient's brain and cause a patient stroke. So those are some of the issues. And in the guideline, they mentioned something about it being standardized. They are trying to make the Valsalva maneuver standardized. So you tell the patient to take a 10 ml syringe. You tell the patient to put the patient's mouth or the subject's mouth on the plunger of the 10 ml syringe and try to push the plunger down. So you're trying to use that force to imitate a Valsalva maneuver. So those are some of the things that you can use for a Valsalva for your vagal maneuver. So things like facial immersion in cold water, which also has been used, and coughing are less likely and no longer used as much, but there are also some forms of vagal maneuver. So if this is ineffective, you want to do your IV adenosine, which is a 1P recommendation. And if that is now ineffective, so you want to give your 6 milligram dose, then 12 milligrams, then want to give 18 milligrams. And this can be considered, you have to watch the patient in case of side effects. So one of the side effects of adenosine is bronchospasms. So you want to be careful in a patient that has asthma, not to cause bronchospasms in those patients. So a history of asthma must be elicited in patients that you want to use adenosine for. So if it's ineffective, you now want to do your IV verapamil or diltiazem and your beta blockers. If it's ineffective, then you still need to go to your synchronized cardioversion. So contraindications to this is SA node disease. Then your calcium channel blockers also are contraindications in suspicion of VT or hemodynamic instability, especially in patients that have heart failure reduced ejection fraction mentioned before. So we'll now go straight to your wide complex tachycardias. So can be VT or an SVT conducted with aberrancy or retrograde conduction over an accessory pathway. Drugs used in management of SVT are dangerous for VTs. Therefore, default diagnosis should be VT until proven otherwise. Differential diagnosis include SVT with aberrancy, that's bundle branch block, pre-existing aberrancy during tachycardia due to longer refractory time of your bundle branch block, SVT with anterograde conduction, that's your antidromic. I have examples of ECGs here, can be activated during atrial fibrillation, atrial tachycardia, AV, NRT. Then also electrolyte derangements can induce QRS widening, like I mentioned before, and it could be a pacemaker induced. So this is basically VT. So I'm just trying to show an example of VT. We can see the AV dissociation, that we can see the P waves in varying positions on this ECG here. Then you can see, I don't know whether I signified whether there was a capture beat and fusion beat here. So yeah, I can't really see what I wrote at the top, but I'm sure it's signified as a capture beat and a fusion beat on the ECG. And this is a VT here. So this is a small algorithm to help us differentiate between your left bundle branch block and your right bundle branch block and a VT in patients that have aberrancy. So basically SVT with aberrancy and a VT, you are trying to differentiate them. So this is a small algorithm that shows, I'll leave the slides so that we can see this. We can see the rabbit ear that we see in right bundle branch block. We can see the difference between it and VT, and we can see it in SVT, which you can see an RSR pattern compared to this that we can see in a VT. And we can see this also in left bundle branch block. We can see the difference between it, what you see here, and what you see in an SVT. This is also a summary from the guideline that shows exactly what I just showed in the last page, but for VT, the guidelines, the specific guidelines for VT. So this is an example of what I just showed now when it comes to right bundle branch block. It's obvious here that this is an SVT with aberrancy, preferably a right bundle branch block rather than a VT, because we can see the rabbit ear with the RSR pattern. So this is a VT. We can even see it even from the concordance. I'm so sorry. Let me put this on silent. So we're going to go to acute management of wide complex tachycardia in the absence of an established diagnosis. How would you want to manage a wide complex tachycardia? So if they're hemodynamically unstable, yes, you do your synchronized cardioversion. If no, then you want to do your vagal maneuver. Then you want to give your IV adenosine. If no evidence of pre-excitation on resulting ECG, and if ineffective, you want to give your IV procainamide or your IV amiodarone. in these patients. If ineffective, you want to go back to your synchronized cardioversion. So we've dealt a bit with regular tachycardias, SVT, regular tachycardias. So we're now going to delve into the irregular tachycardias, the management. So you have a wide QRS irregular tachycardia, is usually atrial fibrillation. Rarely polymorphic or monomorphic tachycardia can present with irregular tachycardia. If patient is hemodynamically unstable, cardioversion is indicated. So now I'll be talking about the specific SVTs that I mentioned before, your sinus tachycardias down to your AV-NRT. I'll be making short notes on each and every one of them. So we'll start with the obvious one, sinus tachycardia. It's defined as a sinus rate greater than 100 beats per minute. P wave is positive in lead 1, 2, AVF, and biphasic or negative in V1. So what are the physiological causes of this? Emotion, physical exercise, sexual intercourse, pain, pregnancy. Pathological, you have anxiety, panic attacks, then drugs, epinephrine, illicit drugs, amphetamine, and coffee, which could be normal. So this is a normal sinus tachycardia. Then how would you manage? First, you want to go for the cause of the sinus tachycardia first. So you want to treat any reversible cause that is present in the patient. If ineffective, then you want to do your ivabradine. That's a 2A and a B recommendation according to the ESC guideline. Or you want to do your beta blocker, which has a lower recommendation with a C. Then, if ineffective, symptomatic and recurrent sinus node reentry. If you now find out that there's symptomatic and you find out that there's subsequent or recurrent sinus node reentry, which I'm going to talk about next, which is the next form of sinus tachycardia. If yes, drug therapy is derived. Then say if it's yes, in the presence of a normal heart with normal ejection fraction, you want to do verapamil or diazepam. Remember, you don't want to use those drugs in patients that have reduced ejection fraction. If no, you want to use ivabradine with, then now you want to mix the two medications together. You want to do the ivabradine and the beta blocker together. And if drug therapy, if drug therapy is desirable, you can use it. Then if the patient does not want to use drug therapy, there's also room for catheter ablation in these patients. And if drug therapy is not effective. So we'll now be moving to inappropriate sinus tachycardia, also known as IST. And it's defined as rate of 100 beats per minute at rest or minimal activity that is inappropriate to physical, emotional, pathological, or pharmacological stress. Mechanism is poorly understood, but it has been associated with a gain of function of HCN 4-channel familial form, and it's associated with tachycardia induced cardiomyopathy. So IST, the diagnosis is basically of exclusion. So the differentials for this is going to be POTS, which is known as postural or orthostatic tachycardia syndrome, SA nodal reentry tachycardia, which I mentioned before, and atrial tachycardia. And the management also will be, like I mentioned, for sinus tachycardia, ivabradine and or a beta blocker in symptomatic patients, which is a 2B recommendation. So we'll now go to SA nodal reentry tachycardia. This is a reentry circuit involving the SA node and is characterized by paroxysmal episodes of tachycardia. ECG P waves are similar to sinus P waves, and diagnosis is suspected on ECG and confirmed. So it's only physiology studies that you can do this diagnosis. So your therapy for these patients will be empirical. It will be obviously if beta blockers are ineffective, you want to use your dihydropyridine calcium channel blockers in symptomatic patients without heart failure or reduced ejection fraction. Catheter ablation in patients who do not respond. So you can also use catheter ablation in these patients that do not respond to drug therapy. Then we now go to postural orthostatic tachycardia syndrome, which is known as POTS. It's a syndrome characterized by an increase in heart rate greater than 30 beats per minute when standing for 30 seconds and an absence of orthostatic hypotension greater than 20 millimeter mercury drop in systolic blood pressure. The prevalence is 0.2% in females and adolescents 15 to 25 years. Spontaneous recovery on 50% of patients in 50% of patients in 1 to 3 years, and the diagnosis also, like the previous one, is based on exclusion. And you can also do this with a 10-minute active stand test, which it will show from the increase in heart rate of 30 beats per minute by standing. So management, it could be non-pharmacological. You can increase the patient's salt and water take to increase volume. You can do graded exercises to make the patient more, to help with the symptoms of POTS. Then you can do midodrine, I'm sorry, everyone, as one of the drugs, and low dose propranolol. So we'll now take another step now. We have left sinus tachycardia. We're going to go to focal atrial tachycardia. So this is an organized atrial rhythm greater than 100 beats per minute, initiated from a discrete location and spreading over the atria. So ventricular rate varies depending on the AV nodal conduction. So the diagnosis is made from 12-lead ECG during episodes, which is very critical to diagnose, because some of these forms of arrhythmias, you barely see them on your 12-lead ECG. Bearing in mind that your 12-lead ECG is like 10 seconds and is most times paroxysmal. Depending on the rate of the tachycardia, P wave may be hidden in the QRS complex. Particular side of AT, that's atrial tachycardia, is the crista terminalis, mitral and tricuspid annulus, and within the pulmonary veins. So when you're trying to find out, so what happens when you look at a rest ECG, and maybe you are fortunate enough to catch a focal atrial tachycardia, you can use the P waves at that point in time, since we know that it's only from one discrete position, to be able to kind of make an estimation of where probably this arrhythmia is coming from. So if you have a negative P wave in V1, you're thinking of the lateral right atrium. You have a negative P wave in 1 and AV, you're thinking of your left atrial origin. You have a negative P wave in your inferior lead, you're thinking of a caudal region, because it's negative in your inferior lead. So it's coming from somewhere below. So for acute therapy of these patients, if they come in symptomatically, you want to do a beta blocker and a calcium channel blocker can be used. Class 1A and class 1C and 3 drugs can also be used to increase refractiveness so that it can reduce, so it acts on the site of that is causing the tachycardia, so it increases the refractiveness, thereby reducing the arrhythmia. Amiodarone can also be used for cardioversion of the patients. So these are all examples of what focal atrial tachycardia, in which I'll be talking about MAT next, which is multi-atrial tachycardia. So this is an example here. We can already see the arrows here of what a focal atrial tachycardia. So the P waves always look the same. It's almost like they're coming from the same location. So we can see one here, we can see one there. So those are all signs of a focal atrial tachycardia. I will drop this slide so that everyone can look at, because there are 3 variants here of 3 different atrial tachycardia, to help localize the location of the atrial tachycardia from just baseline ECG alone. So how do you manage this patient? So as usual, you want to start, is the patient even stable? So if the patient is not stable, you want to do your cardioversion. Then if the patient is stable, you want to do your adenosine as usual. Then if that's ineffective, you want to go to your verapamil or your IV beta blockers. If that is ineffective, you want to go to your flecainide, and you want to go to your class 3, class 1C drugs, and your amiodarone. So that was for acute management. Now we're going to talk about chronic management for focal atrial tachycardia. Is it recurrent or is it incessant? If it's recurrent and incessant, they'll benefit. This is a 1B recommendation from catheter ablation. If no, it's not recurrent, then you want to do drug therapy for the patient. And if that's not desirable, then you can go opt for a catheter ablation for the patient. So if they would like to do a drug therapy, then you want to do beta blockers or your calcium channel blockers or your 1C agents. Then if that's ineffective, you want to do your ivabradine with a beta blocker. Then your last course of action would be amiodarone. And if amiodarone does not work, you go back to the catheter ablation for those patients. Then you now go to multifocal atrial tachycardia, which is a rapid, irregular rhythm with at least 3 distinct morphologies of P waves on the surface ECG. And is associated with underlying conditions, which include pulmonary disease, pulmonary hypertension, coronary artery disease, and others. There's a distinct isoelectric line, unlike atrial fibrillation between P waves. So you see 3 different types of P waves, but it's not going to be fibrillary. You're going to see those P waves and they're going to be clear that there are different morphologies. So from this ECG here, from this, you can see that this one is different from this one. You can see it's different from this one. Also similar to this ECG here, you can see this is different from this, and it's different from this, it's different from this. So this is a MAT. So what are the recommendations for acute and chronic management of MAT? So treatment of the underlying condition, which is very important. Like I mentioned before, MAT can be caused by pulmonary conditions, patients with smokers, they can, pulmonary hypertension in particular can elicit MAT in a patient. So you want to treat what is causing it in the first place. Therefore, 2A, you want to give an IV beta blocker. That's for acute management. I think, so it's almost the same thing as a focal atrial tachycardia. I want to give your IV beta blockers. You want to give your calcium channel blockers. Therefore, chronic management also, if the patient is symptomatic and patient has recurrent symptoms, you want to, if the patient does not have heart failure, you want to give your calcium channel blockers. Then a selective beta blocker should be considered for patients with recurrent symptomatic multifocal atrial tachycardia. Then also your ablation also can be done. You can do an AV nodal ablation followed by pacing in those patients. That's a 2A recommendation. Should be considered for patients with LV dysfunction due to recurrent multifocal atrial tachycardia that is refractory to drug therapy. So we're going to enter our macro reentrant tachycardia, which include your atrial flutter. So it's known as a sawtooth pattern. ECG with flutter-like appearance are mostly due to macro reentrant circuits, but micro reentrant circuits also are very possible in those patients. So they are divided into your cavo-tricuspid isthmus MRAT, which is your typical atrial flutter, which is a common one, and the reverse. So the common is actually the counterclockwise one, and the reverse is the clockwise one. Then you have your lower loop re-entry. Then you have your non-cavo tricuspid isthmus dependent macro reentrant atrial tachycardia, which is known as your atypical. Oh, my internet is working. Okay, your atypical flutter, which is divided into your right atrium MRAT and your left atrium MRAT. So let me talk briefly about your typical atrial flutter. Usually, impulse is from the lateral wall, then slowly goes down to your cavo tricuspid isthmus, back up through your atrial septum. I'm going to give there's a diagram for this. Back up through your atrial septum and posteriorly through your tricuspid annulus. So this is what it looks like. You can see your cavo tricuspid isthmus here. You can see your IVC up here. You can see your SVC up here. So this is your tricuspid annulus. So we can see that this is where your circuit goes around in between this cycle. So this is where the macro reentrant circuit goes around. So for your typical atrial flutter, which is the most frequent cavo CTI dependent flutter, the superior part may be anterior or posterior to your SVT, like what I showed before here. To your SVT and seen as anti-clockwise when seen. So when you're looking, depending on where you're looking at it, if you're looking at it from the apex, it looks counterclockwise, and that's the direction we're looking at it from. The opposite direction is clockwise with different ECG morphologies. So the diagnosis is based on ECG, where you have your counterclockwise, where you see your negative sawtooth waves in your inferior leads and a positive one in your V1. I'll have an example of that. And in your clockwise, you have a positive P wave in your inferior leads and negative in your V1. So this is typically what your typical atrial flutter looks like. We can already see in your inferior leads. We can already see the negative deflection, your sawtooth appearance in your 2, 3, and we can also see it in your V1. So this is what your typical atrial flutter looks like. And we can also see the circuit here, which I mentioned before. Now we're looking at it from almost like you're looking at the heart from the apex. So you can see the IVC down, your SVC up. You can see your tricuspid, your terminal crescent, which is part of your posterior wall here. You can see it going this way, which you know that this is counterclockwise. I don't know whether this is clear, but this is an example of what it looks like for your counterclockwise. If you look at your lead 2 and lead 3, you can see negative P waves or sawtooth waves in your 2, 3, and AVF. Unlike your clockwise, which is in B here, which when you look at 2, 3, and AVF, you can see that it's almost like the P waves are positive. That's how you know that you have a counterclockwise here and you have a clockwise atrial flutter here. So it's based on negative P waves in your 2, 3, and AVF. So for your typical atrial flutter, usually is reproducible on the ECG because of the strong anatomical correlation, but can be modified by surgery or antiarrhythmic agents. Atrial fibrillation and atrial flutter can coexist in the same patient. Atrial flutter can occur in patients with atrial fibrillation being treated with class 1C medication. It's actually quite common in literature that patients that have been treated with atrial fibrillation, that they revert when they are being treated with class 1C medication to atrial flutter. So they go back and forth. Antiarrhythmic agents can also cause widening of your QRS complex. So how do you manage this type of arrhythmia? Acute therapy. So for high ventricular rate in symptomatic patients, you want to do a rate control. Cardioversion is usually necessary if drug therapy fails. Care should be taken in the use of AV nodal blocking agent. I think we had a question like this, especially adenosine can lead to atrial fibrillation or a one-to-one AV conduction. I think we've handled an MCQ that mentioned something like this. Amiodarone is not effective to revert back to sinus rhythm, but may be effective to reduce the heart rate. High atrial stimulation can be used to revert atrial flutter through atrial fibrillation with ventricular rates. Is easier to control. So catheter ablation, most effective to maintain sinus rhythm. So catheter ablation is the most for atrial flutter because of the anatomical correlation of atrial flutter. It's very easy to do a catheter ablation for those patients, especially when they are symptomatic. Also indicated in antiarrhythmic agents induce typical CTI-dependent atrial flutter from atrial fibrillation. So you do, like I said before, in literature, it has been known that when you use antiarrhythmic agents with atrial flutter, they revert to atrial fibrillation, they refer to atrial flutter, and that is an indication for catheter ablation. So for chronic therapy, you have rate control can be used for symptomatic patients, which include your beta blockers and your verapamil. Amiodarone also can be used for patients that have structural heart disease and heart failure. So if a patient has atrial flutter and atrial fibrillation, you have to also do your thromboprophylaxis for the patient. So data is not as strong, or papers are not as strong for use of anticoagulation in atrial flutter as it is for atrial fibrillation. Atrial fibrillation has been vastly studied for anticoagulation. But if you see a patient that is falling in between atrial flutter and atrial fibrillation, it would be wise to put the patient on thromboprophylaxis. And a patient that you know that maybe when you're not seeing the patient, that there's a high risk of atrial fibrillation, it would be better to put the patient on thromboprophylaxis. So other carbo-tricuspid isthmus-dependent MR-AT are the lower loop reentry circuits around the IVC rather than tricuspid annulus. It could be clockwise or anti-clockwise, and you have the figure 8 double loop. These are just extra. So these are just examples of your non-CTI dependent MRT. I'm going to leave that on the slide for everyone. Then we'll move swiftly to your atrioventricular junctional arrhythmias. This denotes reentry in your AV node. Evidence has shown right and left inferior extension of the human AV node and atrionodular inputs that may be substrate for slow pathway and can be divided into your typical, which I have mentioned before, which is your slow fast. Slow fast is your typical, and your atypical is your fast slow. So diagnosis can be made on an ECG with narrow complex tachycardia, but can be widened QRS complex, usually from a functional RBB block or a pre-existing.
Hey, look at the bed. Just raise your head. Raise your head.
Hi. Should I go back?
Raise your head. Can you see the before the head?
Okay. It's not talking to me.
Sorry, it's
Oh, okay. My apologies, everyone. Sorry. So as I was saying, narrow complex tachycardia, but can be narrow complex tachycardia is usually a narrow complex tachycardia, but it can be widened, obviously, if there's a functional bundle branch block in those patients. So you can see an AVNRT with a widened QRS complex. You can have ST depression also can be seen during tachycardia. So this is the etiology of this is a schematic showing what can happen in your AVNRT. So you have impulse entering your AV node, you have your slow pathway, you have your fast pathway, right? But what now happens is that you have a premature beat, right? That hits this slow pathway and now goes here, but this pathway is still in a refractory period. So what now happens is that it goes in. So it's that premature beat that now causes the cycle that now goes around, because it hits this slow pathway when it has already finished its refractory period. It enters into the ventricle, but it now hits the fast pathway when it's just relieving its own refractory period. So by the time it now goes back up through this pathway. When it now goes back up through this pathway, instead of it to be aborted by this fast pathway, this one has already finished its refractory period. It now starts going back again because this slow limb, by the time it's coming back up, has already finished its own refractory period. So it starts going around. Let me go back again. So on a normal day, what happens is that you have your normal beat. It goes here. It goes into the ventricle, right? So in between that time that it has gone through the ventricle, into the ventricle, what now happens is that there's now a premature beat in between that period, in between the time that it has gone round. What now happens is that the premature beat, this slow limb has gone through its own refractory, it has gone through its own refractory period. But instead of it going down fully into the ventricle, it now goes this way, because by the time it has gone through this slow limb, this limb has already finished its own refractory period by the time it goes down. Then it now goes up and now goes back into the atrium. And what now happens is that this premature beat now causes a cycle around the AV node. I don't know if I'm able to explain this properly, but it's caused by a premature beat into the AV node. So maybe after the presentation, maybe somebody that has a better knowledge can help us explain it. But that's how I understood it, that immediately a premature beat comes in when this one is in refractory period. This limb has finished going through its refractory period, but this place, it can't go down because this one is still in refractory. Meanwhile, this one has finished its refractory period. So instead of going down, it goes back up and now enters back into the atrium. And what now happens is that in a cycle is now propagated around the AV node. So maybe after the presentation, we would, somebody might have a better knowledge and give us more clarity. Typical AVNRT is a retrograde P wave that is related to the QRS complex and most times are not seen. So as I mentioned before, we have your RP. Your RP is a representation of your slow-fast pathway. So if you have a typical AVNRT, your RP is a representation of it going from the ventricle back to the atrium. So if you have your slow-fast, your RP will be slow. So therefore, you have a slow RP tachycardia. That is why your RP is less than your PR, and therefore is less than 1, which causes a longer PR due to the slower activation of the atrioventricular conduction. So the ECG criteria, which also makes sense, is a pseudo R wave deflection in your V1, which shows your retrograde P wave also that is coming. So that's what is showing in your V1. We also have a pseudo S wave in your inferior leads also, which is also because of the pseudo P wave. So it's showing like an S wave in your inferior leads. Then you have also a notched AVL, and you have a pseudo R in your AVR, which shows that, because that's an R wave, it shows that something is going towards your AVR, which is not supposed to be so. So it shows a pseudo R, which is a representation of your P wave that is going the opposite direction. So these are the classifications. I don't want to go through too much through this, but it's basically what I have explained about the RP and the PR. But the representation here is for electrophysiological studies, when you're talking about the His atrial interval and your ventricular atrial interval. So for your atypical, that's what we're now talking about, your fast slow, which means that your RP now, because it's a fast slow, so your RP is now greater than your PR, which is now greater than or equals to 1. Your P waves are discernible before the QRS complex, and they are usually classified by HR, that's your His atrial interval or ventriculoatrial interval measuring in the His bundle electrode. So these are the examples of all of this. I don't want to confuse anyone, but each of them show ECG. So you can see your slow, you can see your P wave here. But the most common form of your AVNRT is that you won't even see any P wave at all. That's your fast, slow pathway most times. But, or you can see it after your QRS complex. So these are examples of all the types of AVNRT. I don't want to bore anyone by going through all of this. So management of AVNRT, you have your vagal maneuver and your adenosine. I've mentioned the types of vagal maneuver and how you use your adenosine. Then the next thing is your catheter ablation, which is the current treatment of choice for symptomatic patients as it improves quality of life. Recurrence can occur about 3 months post-ablation, but younger individuals less than 18 years, occurrence can occur after 5 years. It's 2% success rate with a 1% rate of heart block occurs after catheter ablation for AVNRT. So this is how you manage AVNRT. You have your acute management and you have your chronic management. So we'll start with your acute management. Patient out of hospital, that's for your acute management. You want to do your, if yes, that means if you see a patient with AVNRT, you want to do your vagal maneuvers, which I've talked about. You say out of hospital, that means the patient is in hospital. No, is the patient hemodynamically unstable? If yes, you want to do your cardioversion. If no, you want to do your vagal maneuvers also. If that is ineffective, you want to do your adenosine. If that's ineffective, you want to do your verapamil. You want to give verapamil or IV beta blockers. If all of that is ineffective, you want to do your cardioversion. So for your chronic management, you want to find out, is it symptomatic or recurrent? If yes, you want to do your catheter ablation, which is a 1B recommendation. If no, you want to do drug therapy. If drug therapy is desirable, you want to do your calcium channel blockers or your beta blocker, or you want to use both together. If no, they don't want to take drugs, you can go straight to catheter ablation for chronic management of AVNRT. So this is another form of SVT, which is your non-reentrant junctional tachycardia, which is also known as JET. Occurs from abnormal automaticity at the AV node or proximal to the His bundle, and can be congenital in children or from post-infant heart surgery, and can also be seen in adults with normal hearts. So for the ECG, what would you see? Is also a short RP interval form of tachycardia. You see a narrow QRS complex, and there's AV dissociation in this patient because, mind you, this is a junctional tachycardia. So it might be irregular, but also look like atrial fibrillation. So the treatment for JET is propranolol, verapamil, procainamide, and can be used for acute therapy. Amiodarone can also be used in infants to prevent post-op JET. Flecainide can be used in patients without structural heart disease. So we will now go down now to your AVRT, which is, I think, the last SVT here. So you have your reentrant circuit that contains 2 limbs, which has different refractoriness and conduction times. So you have your AVN, you have your accessory pathway, and can have your pathway also in your AV node. On rare occasions, the 2 circuits, that's the 2 retrograde and the antegrade limbs, can both be accessory pathways, which is quite rare. Most times they use this type of tachycardias use the AV node as part of the retrograde or the antegrade limb. So accessory pathways are single-stranded myocardial cells that bypass the conductive system of the heart and connect the atrium to the ventricle. It could be from incomplete formation of the atrial annulus. So 60% of this can be found in the left atrial free wall, 25% is in the septal aspect of the mitral and tricuspid annulus, and 15% is in the right atrial free wall. So this is something we all know. So yeah, so we can see the normal consumption. We can see that we have a pre-excitation pathway here. So we can see that I'm going to be starting from this. You can see this is an accessory limb, of which the conduction passes through the accessory limb. And so this is what leads to pre-excitation that causes your delta wave, your short PR interval, your accessory, your delta wave that merges with your QRS complex. So this is pre-excitation. Then you have your autodromic. So what happens in your autodromic? This is a narrow complex tachycardia. And why is this narrow complex? So the antegrade goes through your AV node. So we all know that in the AV node, there's a pause. So because of this pause, and you're passing to the his Purkinje fiber, so it's going to be narrow. But immediately it goes through the limb again, then it passes through the AV node. So this is going to be a narrow complex tachycardia because of the fact that it passes through the antegrade limb passes through the AV node. Unlike your antidromic, what happens in the so the activation of the ventricle is primarily through your accessory pathway here. So we can see that the antegrade limb here is from your accessory pathway and is going down here. So it's going to cause a wide complex tachycardia. Why? Because it's not passing through your his Purkinje fibers. It's doing cell-to-cell conduction. And if it's doing a cell-to-cell conduction and it's not passing through specialized conduction tissue, what happens is that the QRS complex becomes widened. That's what leads to your antidromic AVRT. So this is your antidromic. Then this is your autodromic. And autodromic is the most common, AVRT. So has a faster conduction rate and causes cause of the sodium channels, like have a faster conduction rate because of the sodium channel, sodium current, like myocardial cells. So you now have your manifest pathway, like I mentioned, I think I mentioned earlier in the presentation. So the kind of accessory pathways you can have are your manifest. So every ECG you do for the patient, you will see that pre-excitation manifesting in sinus rhythm. That's your manifest pathway. Then you can also have a concealed pathway in which you can have a retrograde accessory pathway. Then you can have a latent pathway. This is going to be barely visible due to the location or conduction through the AV node. So those are the three types of pathways you can have. You can have your manifest pathway, which at rest, if you do, I'm sure we have patients like that in our clinics where we do ECGs for them, and you see pre-excitation in clinic. So those ones have the manifest pathway. Then you can have your concealed pathway, in which you have a retrograde AP, so you might not even see it on rest ECG. Then you can have a latent, which is in your AV node. Then your autodromic, which I mentioned before, that is the most common, is greater than 90% of AVRT, 20 to 30% of all sustained SVT. Your retrograde limb is your accessory pathway, as I mentioned before. Antegrade limb is your AV node. Tachycardia is usually 150 beats per minute, usually greater than 220 beats per minute. And your ECG, your PR, your RP interval is not usually constant. You have your narrow QRS complex. You can have a functional bundle branch block as the AP ipsilateral to the blocked. The accessory pathway can be ipsilateral to the blocked bundle branch. You can also have an ST segment depression also from this patient because you're going to have depolarization abnormality. So these are examples of, I have to show you what I'm talking about here. Sorry, everyone, give me a minute. So these are examples of, sorry, give me a minute, please.
Okay, ma'am.
Sorry, everyone. I'm trying to get I'm almost done. Are you people seeing my slides, please?
No, it went off.
Is it off now?
It's
Is it
off.
on? Is it on?
Still,
it's still off.
it's,
Okay, I'm coming. Give me
yes.
this. Sorry. I'm trying to make it clearer. In 5 minutes or so, I should be done. Can you see it now? Can anybody see it now?
Not yet, please.
Okay.
Oh, sorry, I cannot see it.
All right, let me share. Sorry, everyone. Apologies, please. Can everybody see it now, please?
Yes, your screen is, I can see your screen now.
Okay. So this is an example of a patient that had a tachycardia of about 180 beats per minute. So we can see that this was an autodromic AVN. He has obviously a narrow complex tachycardia. He also has something that looks like, if you look closely at some of the QRS complex, you can see a slur. It's going to be very obvious post-adenosine, especially in 2 and 3. You can see almost like a slur. Let me go to the post-adenosine. Can you see the shortened PR interval here? And almost like a slur that is going here. So you can see the shortened PR. So this patient had an autodromic AVRT. Post-adenosine, it now became very clear, but you couldn't discern a P wave in the prior ECG. So when the patient was given adenosine, it now became very clear that this was an autodromic AVNRT because of the shortened PR interval. And you can see in the P wave, there's almost something that looks like, you can see in the lead 2 that there's almost something that looks like a delta wave. So this is an example of a patient that came in an emergency and had an SVT and was managed with adenosine, and it showed post-adenosine and autodromic AVRT. So for your antidromic, that's the wide complex tachycardia. You have your 8 to 5% of patients with Wolff-Parkinson-White syndrome. You have your retrograde limb as your AVNRT, your AV node, and your antegrade limb as your accessory pathway. So ECG for these patients are wide complex because of the way I described before that the pattern goes. So it's a cell-to-cell conduction thing. So most times they come as wide complex tachycardia. So we'll now go to Wolff-Parkinson-White syndrome, which is also a form of AVRT, which can come as an overt or a manifest accessory pathway. So typically you have your short PR interval, you have your slurred upward stroke or downward stroke, you have your widened QRS complex. So there are varied degrees of pre-excitation, which depends on the location of the accessory pathway as well as the AV node conduction properties. So this is a classic example. We can see a wider QRS complex compared to the one I showed you before that just had pre-excitation with a shortened PR interval. This one has a wider QRS complex with a shortened PR interval, and also depolarization changes. You can see the T wave inversions that the patient has also showing that there's some depolarization or repolarization, sorry, abnormality. So this is just a schematic that can help you in terms of ECG to help you to localize accessory pathways. So there are different algorithms that are out there in how you can use plain 12-lead ECG to decode accessory and location of accessory pathway. And this picture is very helpful because with this, you can see your tricuspid. It's almost like a short axis view where you can see your tricuspid and your mitral valve. So with this, most times they use it to, this is the kind of image they use to be able to localize your accessory pathway. This is even a better image. So when you see this is the anterior, anterolateral, your lateral, your posterolateral, your posterior, I think most of us are. So this is how it looks. But how do you relate it now with your ECG? That's the question. So you can see both your tricuspid and your mitral here. So you can see that what your baseline ECG looks like. You have your V1, your V2, your V3, your V4, your AVL, your 3, AVF, and 2, and your 1. So this is what you basically use most times. This is what is used by most of those very complex algorithms, I must admit, to be able to localize accessory pathways. So this is just for us to know that there are some ECGs, on plain ECG, you can also localize an accessory pathway. And once you have a negative delta wave on the right side, on the right-sided lead, that's your V1, showing that it's negative. You most likely have a right-sided accessory pathway. If you have a negative delta wave in your left-sided leads, that's your 1 and AVL. Most likely is a left-sided accessory pathway. If it's isoelectric delta wave in V1, you have an anteroseptal accessory pathway, which would also come with a posterior delta wave in the inferior lead. This is very complex, so I'm going to leave it. I don't think it's necessary for exams. So this is also a summary of those things also. You can read it after. So this is also an example of what an ECG of antidromic also looks like, reentrant tachycardia, due to a concealed posteroseptal accessory pathway. Like I mentioned, if you have a posteroseptal accessory pathway, most times the P wave is going to be negative, or the delta wave, the P wave is going to be negative in your in your inferior lead because it's going away from those leads, as you can see in this ECG. I'm going to be dropping all the slides on the group, so I don't want this presentation to be too long. I've already taken a lot of your time. So how do you manage AVRT? Is the patient in the hospital or a patient not in the hospital? So if the patient is not in the hospital, ideally you want to do a vagal maneuver for the patient. If the patient is hemodynamically unstable, you want to do your cardioversion per usual. Then if no, you want to do your vagal maneuver. Then you now want to find out if the patient has orthodromic, yes, you want to do your adenosine. If the patient does not have orthodromic, you don't want to do adenosine because we are not sure what is going on. That means the patient is going to have something that looks like a wide complex tachycardia. You want to be careful then. You now want to think of things like prokinamide. You want to think of cardioversion or synchronized cardioversion for the patient to play safe. Then if the patient has orthodromic, that's your narrow complex tachycardia, you want to give, if your adenosine is ineffective, you want to do your IV verapamil, diazepam, or your beta blockers. And if everything is ineffective, you just do your synchronized cardioversion. So this is for your chronic therapy. As we said before, AVRT is catheter ablation. That's a 1B recommendation. If the patient does not want to take drugs, catheter ablation should be your first course of action. Then if you want to now give medication, especially if it's orthodromic, you'll be thinking of your 1C drugs or your calcium channel blockers or beta blockers. So I think we've talked about pre-excitatory AF before. So you can, for those type of patients, you have Wolff-Parkinson-White with atrial fibrillation in those patients. So how do you manage those patients? Is patient hemodynamically unstable? Yes, you want to do your synchronized cardioversion as a 1B recommendation. If no, you want to do your flecainide or you want to do your prokinamide for those patients. If it's ineffective, you then want to now do your synchronized cardioversion. So I'm going to leave this on the slide. So there are also atypical forms. This is just for us to just know. Atypical forms of pre-excitation, which is known as your hand fibers, which is a connection in between your right atrium and or your AV node and your right ventricle into or close to your right bundle, to your bundle branches. And conduction is usually anterograde only, and can present with normal QRS with pre-excitation with left bundle branch morphology. Antidromic AVRT can occur in these patients due to your anterofascicular pathways. So these are some examples of the pathways which we can further read. So we can see some AV connections here, anterofascicular tract connections here, fasciculoventricular tracts and noduloventricular tracts. So thank you everyone for this presentation. I know it was long. I hope I was able to say a few things about SVT. Thank you. Oh, 1 hour, jeez.
Yes.
I'm so sorry. I apologize.
No, it's quite much voluminous. Thank you so much, ma'am. I don't know whether Dr. Opopi is still there. I know it came in while the lecture was going on. Okay, he's not here. So please, we would like to ask for contributions and comments. Dr. Precious has done a wonderful job of trying to summarize this. And thank you so much again, one. Thank you so much again. Please, we have questions, comments. Okay, from the chat box, people are saying thank you, oh, as in the big oh, like you've really done a big thing for us. So thank you. So thank you so much, Dr. Precious. You did manage the time well. So just people being very grateful for the presentation. Please, if there are comments, we can kindly raise up our hand so that at least.
I hope I was able to convince you and not to confuse you.
Debate. So nice person. Okay, kindly drop the slide. Okay, so it seems as if you've convinced them. I'm not sure there's any confusion. So once again, thank you so much, Ma. We are very grateful for this. Nobody's up for the question. We are very, very grateful, Ma. Thank you. Okay, so without wasting too much time.
Sorry, Chief. Somebody, Dr. Sawa had a question, ventricle to atrium in AVNRT. So I think there was a question. I think he was the first.
See.
He was the first person to. So what happens in AVNRT? I think he was the first person that wrote it. A question, Chief Sawa. Happy? Yes. So what happens in AVNRT is that it first starts from the atrium. The trigger starts from the atrium. It enters into the AV node, the short. Then it goes through the AV node. Then as I said before, that is always triggered by, what do they call it? By an ectopic beat. So what now happens is that it goes up into it doesn't enter into the atrium. It just starts going around. It's like a micro reentrant circuit around the AV node. That's what starts to happen. But in electrophysiology studies, how they put it was that they put it as a his atrial interval or a ventriculo-atrial interval, because how they are taking it is that from the ventricle is going back up. So that's how they're going to put it. They're going to put it as a ventriculo-atrial interval because it's going back up the AV node. So in EPS, that's how they wrote it, as a his atrial interval or a ventriculo-atrial interval. That's how it was described as in EPS studies. I don't know, Chief Sawa, I don't know if I'm able to, because it's going back up. That's why they mentioned it as like that, so that they can give it a time range for EPS. But entering the atrium per se, I don't think so. It's just a circuit in that AV node going around. Chief Sawa.
Okay, am I audible?
Yes, sir, you are, please.
Okay, thank you very much. It was a lovely presentation, and I can imagine how much effort you've really put into this.
Oh, okay.
Yes. One important thing I think we should pay attention to in AVNRT is that first thing to note, like you rightly said, there's a circuit around in the AV node. Normally, everybody has that. Okay, it is not a pathological thing. And one of the circuits is a fast track. The other one is a slow track. Each of them have
Okay, Dr. Sawa. Dr. Sawa. Okay, maybe it's network. Am I the one that can't hear him again? Please, can any other person hear Dr. Sawa? My network.
No.
Come back. But while we are doing that,
depolarization and repolarization were informed and slow pathways.
okay. The line is off eventually. Network. Please, Dr. Today, can you help us share the Harrison while we wait for Dr. to come back? Chief Sawa, are you back?
Yeah, I'm back. So sorry. This network these days, I don't know.
We had the first.
Okay. While
Hello,
it's
sir. We had the first seconds of what you were saying when you were talking about there is a normal circuit and an abnormal circuit. That was the last thing that I heard. Then there was a period of prolonged pause, so you just came back.
Okay, can you hear me now?
We can hear you. I can hear you now, sir.
Okay, thank you. I said every normal person has that circuit. Is normal.
Yes, sir. Okay, so it's normal. And
Yes, it's normal.
Okay.
It's normal. It's a normal thing. It's physiological. Okay. And the normal part to circuit is that it goes through the fast. By the time it's going to go round that circuit, it will find out that the slow one is still refractory. So it's going to halt the circuit there, while it's allowing only one to go down the ventricle, and the circuit continues like that without any entry in the AV node. Okay, so like she rightly said, an ectopic beat is what triggers the confusion. And this ectopic beat must not necessarily come from the atrium. It can also come from the ventricles. Okay, so now by the time that ectopic beat comes and it finds at that point the slow pathway has already completed its refractoriness, ready and willing to accept any depolarization, it triggers the cycle. And by the time it's now going back, since the repolarization of the fast pathway is already fast, it will now find it ready and receptive to depolarization circuits, and the cycle will now continue. So it now continues to turn around and around that circuit like that. I don't know if you get my explanation. Hello?
Yes, sir.
Chief, we understand.
Okay. Yes. So it is even possible with that circuit. Okay, it doesn't mean that you are having a depolarization from the ventricles to the atrium. No, you can only do that when you are talking about an accessory pathway. So that circuit that continues around that AV node, is possible that you are even going to get a simultaneous depolarization of your atrium and the ventricle. That is why sometimes you might see the P wave is even buried inside your QRS complex. Okay, so yes, you're correct. EP studies depicts those intervals as ventricular, that's the VA interval, but it doesn't mean that depolarization is moving from the ventricles
Into the
to the atrium.
Yeah.
It's actually a circuit now around that AV node that is just going in a circular form. And while it's going in that circular form, some of the depolarization can fly to the go and depolarize atrium, some can go and depolarize the ventricle. That's the clarification I want to make.
Thank you, Chief.
You're welcome. And the ectopics can come from anywhere. It must not necessarily be the atrium. It can come from the atrium, it can come from the ventricle to offset that normal physiological cycle. Thank you.
Thank you.
Good evening. The question I want to ask is how would a ventricular ectopic offset that circuit? You just mentioned, because in most of the reading, it's mostly the PAC. So I'm wondering how a ventricular ectopic will be able to offset the circuit, looking at the pathophysiology involved.
Well, from most of the literatures I have read, I'm not sure if they vividly explain how it's going to do that, but I don't want to give a listing, but what I'm sure about is that it's clearly stated that any of the site, either from ectopic from ventricle or from the atrium. Any of them can trigger that circuit.
Dr. Precious, are you still there, please?
Oh, yes, I'm here. I'm sorry. Was there a question for me?
There's
Chief.
a question in the chat box. So I think that Chief Sawa's network went off again.
Oh,
but
about
there's
the
another question in
ventricular
the chat
issue.
box
There's a question in the chat box. Okay.
about SVT aberrancy and VT.
All right. No
Then about James fiber.
About James fibers. Okay. Let me just, so that everything will just make some sense. So that, sorry, everyone, because I think I had some slides on it. SVT with aberrancy and I think I had a table on it even. So this is it. So when we're talking about aberrancy, we're talking about bundle branch block, and that's why I put this table in here. So how would you differentiate between, I think that was the question, right, Dr. Adeyanju? I can't see it anymore.
SVT with aberrancy and VT.
Exactly. Okay. Okay. So this is it. So we can use leads V1 and leads V6 from this algorithm. This is from Wellens. I got the reference is even at the bottom because he's part of the people that were part of the people that made the classical morphology criteria for VT and SVTs. So this is his own version. The reference is at the bottom in case anybody's interested in the paper. So for left bundle branch block, if you are looking at an SVT, when you're looking at V1 and V2, let's talk about what is present. So there's an R wave of greater than, a small R greater than 0.004 seconds, a notched RS downstroke, which is going to be here. As we can see this here. This is the S that we're talking about, a notched down S stroke. That's more likely for a VT. We can see that there's a delayed also S nadir of greater than 0.06. So we can see also, this is the C. So the A version is the R greater than 0.04 seconds. So this is the A. So you see something that is greater than this compared to this, that's an SVT. We can see that the R is greater than 0.04 compared to this, there's an SVT with aberrancy. Oh, my network is misbehaving. Can you hear me?
Yes. Yes, it became unstable. Please, can you go over that again?
Okay. So these are the criteria A, B, and C. And it's also the same thing that is seen in what is here. And this is what you see in a VT compared to an SVT with aberrancy. So what this table is showing is the difference between a VT and an SVT with left bundle branch block. How do you differentiate them? That's what this table is showing. So the first thing you want to do, A tallies to this A. You want to look at the R wave. So the R wave is normally greater than or equal to 0.004, which is not the same thing that you see in an SVT with a left bundle branch block. You ideally see something that is smaller than that R wave, or a Q wave. Then B, you see a notched S wave, which is more in keeping with a VT compared to an SVT with left bundle branch block. So for a VT2, you see a delayed S wave with a nadir greater than 0.06 seconds. So you see that this point to your S is going to be very long. This to this point is going to be very long compared to what you are seeing here that is going to be a Q wave. So this is going to help us somehow know the difference between an SVT with left bundle branch block and this is Wellens criteria anyways, left bundle branch block compared to VT. Then for here also, so now the problem now comes in this V6. So in V6 here, how you can know that it is a VT is that you see just a pure Q wave in lead V6, which you will not see in a left bundle branch block. If we know it's a M pattern, we'll see. Or this type of wave. That's what you see in AVT, which is the same thing that you see in, what they call it again, concordance. So this is almost like a concordance kind of thing that you see in lead V6. I don't know if this is clear, because I think this chart was quite clear. That's why I put it here. Dr. Adeyanju, is this clear? I think for left bundle branch block.
Right.
And
Yes, it is. We are trying to just go through it.
yeah, I think it's very, and it's referenced. This is what
Yes,
I use. This is what I use because it's easier for me. I don't know if it will be helpful. As for right bundle branch block, this is the left, this is the rabbit ear that everybody is always talking about. So for SVT with right bundle branch, you see a small R. You see a bigger right ear than a left ear, unlike VT, where you see a bigger left ear compared to a right ear. So they call it about the reversal rabbit ear appearance for SVT with right bundle branch block compared to VT. So there are some patients that you see that you're thinking that is this a right bundle branch block? Is this not right bundle branch block? Immediately you see that the first R is bigger than the second R is VT. Is VT. Is VT until proven otherwise, compared to right bundle branch block that the first R is smaller than the next R. I think this is a very important criteria. I don't know if this is okay.
It's clear.
I think that is. Then there was another question, I think. I'll drop the slides in the group in case there are any more clarifications that, and I don't know, Chief, is there any other question we're talking about? We're talking about something else. I can't open the chat now.
We're talking about the signs, Brugada sign, Josephine sign.
Okay, that's for VT.
For VT, yes.
Josephine sign. I know all those signs, but I didn't put it on the slide. Should I put it on the slide for, okay, is that what the questions I made there?
Yes, yes. If you can help us put it on the slide before dropping them, or if you can tell us that what is okay.
I could put them on the slide because I don't know how to describe it without an ECG.
All right. Please kindly help us put it on the slide before you drop the slide.
I don't know how would I describe it without an ECG? I don't know. I don't know. Do you understand, Chief, what I'm trying to say? I don't know how to describe it without an ECG.
I understand perfectly what you're trying to say. Please,
hello, Dr. Precious. I think the last slide you showed, Joseph's sign is on it.
Okay, let me share my slide. Let me share. Which slide are you talking about?
The last one you just explained. Your option B is Joseph's sign.
I'm going to share this slide down. This one here.
Yes.
Okay, let me open it up.
You're not S wave.
This one here, right?
Downstroke of the S wave is Joseph's sign.
This B here.
Yes, that is it.
That's Joseph's
when
sign.
you have a left bundle, when you have a left bundle branch block pattern, then you look at the downward, the downstroke of the S wave. If there's a notch, that's Joseph's sign. Then Brugada.
I think it's
the Brugada. I know your C looks like Brugada, but the timing I know is different from what
it's not the same time. The timing I know is 100.
It's 100. Yes.
Timing I know
100
for VT.
Yes, that's it. So that's the problem. Why C? But B is Joseph's sign.
The Brugada is 100 that I know.
Brugada is 100 from the peak of the QRS to the NIDA of the S wave should be greater than 100.
But the issue now is that I used Welling's criteria. So I think that was the problem. You know, Brugada has their own criteria and Welling's too has their own criteria. I think that was why this was 0.66 seconds compared to Brugada that has 100.
Okay, yeah, I don't know about the options.
Yes.
But your B is actually the Joseph's sign.
Thank you so much. Yeah, that's it, actually.
You're welcome.
This two here is supposed to be 100. That's Brugada. but this here is not in keeping. This is 100, it's 100 milliseconds. I think it's maybe
Okay.
because of the reference I used.
Okay, but please kindly still let us put it on this slide before you drop it, ma'am.
I'll find, I think I have a picture on the slide somewhere. No problem.
Thank you very much. Please, are there further comments or contributions? We need to move to the next section as fast as possible.
Okay, you asked about left rabbit ear. I think I've described that, right?
Described it already.
Yeah, okay.
Yes. Please, are there further comments or contributions? Okay. We need somebody to help us share the Harrison question. Dr. Ajayi, please, are you there, sir? Dr. Ajayi? Dr. Florence? Dr. Vuda? These are all our presenters for today. It's okay. Dr. Chineme, I know you're online. Dr. Brown, Dr. Ibe, Dr. August, Dr. Adebayo. Now we have 87 questions left to do in Harrison, and we have to be fast about it. Please, I want to plead, Dr. Yotobi, can you help us share the Harrison question? Dr. Chineme, please, are you there, ma?
Yeah, but my network has been unstable. So in case I drop off again, maybe there's a backup.
Okay, don't worry, you won't drop off, hopefully. I don't know why this thing keep on removing co-hosts. It's disturbing me. Okay, thank you so much. Dr. Chineme, please, are you there? Okay, Dr. Augustine.
Hello, I can hear you. Can you put up that thing?
Thank you. Are you ready to take your part of
Hello?
Harrison? Hello, we can
Hey,
hear
good
you.
evening. I can hear you, but I didn't hear what you said.
Oh, we were asking, we are going straight to Harrison. Are you ready to take your
I'll take, but if somebody has their own, let the person be shaking first. Let me just sort out my kids.
all right, ma? Thank you. Dr. Brown.
I'll take my part. Let somebody start. Let me sort out my kids first.
Thank you, ma. Okay,
Hello,
Dr. Brown.
Dr. Adeyanju.
Yes, please. Dr.
Hello, Dr.
Augustine.
Adeyanju.
Yes,
Okay,
Dr. Augustine.
can you give me like just in like 2 minutes? Let me put my jottings together. I can take mine.
Yes, sir. We'll give you like
Can
2
you just give
minutes.
me 2 minutes?
It's okay,
Okay,
sir.
thank you.
Do that because we
Okay.
only have 2 of you on the call to take your part. I don't know, chiefs. I'm not sure. Maybe we'll have to go and solve this question ourselves eventually. Dr. Ibe Cassidy, please, are you on the call? No. Okay. Dr. Adedeji Adebayo. Okay, please, let's kindly give Dr. Augustine some few minutes to come back to take his part. So we only have Dr. Augustine and Dr. Chineme on the call to take their part. So whatever we decide thereafter.
Okay, I'm ready now.
Thank you very much, sir. Please, sir, what numbers are you answering?
151 to 160. 151 to 160.
Thank you very much, sir.
Okay, 151. So let me try and actually open it on my system. The screen is a bit tiny somehow. So I could just use that to follow. It seems very tiny to read. 151. Okay. Almost there. Less than a minute. Okay, yeah. So 151 said, which of the following statements regarding PE is true? So the options, am I audible, please? Hello?
Yes, please, you're audible.
Okay, so which of the following statements regarding pulmonary embolism is true? A, we have airway resistance usually decrease in the setting of acute pulmonary embolism. B, almost all patients with pulmonary embolism have evidence of thrombosis at the time. C, alveolar hyperventilation is a typical physiologic abnormality in the presence of pulmonary embolism. Then D, hypotension in the setting of acute pulmonary embolism is often due to acute left ventricular dysfunction. Then the last one, E, the size of the arterial alveolar gradient is invariably correlated with the size of the pulmonary embolism. Let me start from the E. So for the E, one of the materials I read said that even though the arterial alveolar gradient can help to determine if patient has a pulmonary embolism, it is said that it doesn't have any significant relationship with the severity of the PE, whether it's severe PE or I can use the word mild or moderate. Okay, just depending on the size of what is causing the obstruction. So it is said for E that it has no relationship with determining the severity of the pulmonary embolism. Then for D, I think that one is a bit straightforward. For us to have hypotension in the setting of an acute pulmonary edema, there has to be a form of obstructive shock, okay, on the right side, not the left side. Okay, so I think that is a straight forward for that. Then option C, alveolar hyperventilation is a typical physiologic abnormality in the presence of pulmonary embolism. So from what I read, that seems to be the right answer. And the explanation is this, that so when we have pulmonary embolism, it is said that biologically active mediators are released by the thrombus, and this can cause bronchoconstriction. And then a greater degree of the regional ventilation redistribution is also found in this group of patients. However, there seems to be a response from the patient, and the patient tends to have a spontaneous response whereby there's hyperventilation, which is demonstrated by decreased arterial CO2 tension. So for patients who have a pulmonary embolism, there's a physiologic response to hyperventilate, which is found in them. Then let me go to B. So it said that almost all patients with pulmonary embolism have evidence of deep venous thrombosis at the time. So a material I saw online said about 90% of patients with pulmonary embolism have DVT. However, when I was trying to read up in the Oxford handbook, it said it gave the value of quoted 50% of patients that will possibly have only 50% of patients have a DVT where in the setting of a pulmonary embolism. However, it's also said that you can have a pulmonary embolism occur de novo, okay, without having deep venous and thrombosis. So option B is not right because they say almost all patients with pulmonary embolism have evidence. From what I found in the Oxford, just about 50% from the Oxford value. So which mean that is not correct. Then option A, airway resistance usually decreases in the setting of pulmonary embolism. So it should be increased, and not just pulmonary. The variables that are affected in pulmonary embolism is that one, you have abnormalities of the pulmonary gas exchange, you have abnormality with pulmonary compliance, and also there's increased airway resistance, and patient tends to do the ventilatory control. So instead of having a decrease, there will be decreased airway resistance in the setting of acute pulmonary embolism. So from this option, C is right because patient tends to have a physiological response once pulmonary embolism comes when they have pulmonary embolism, and the response is more of a hyperventilation. I don't know if there are contributions or additions. Thank you. So we can move to the next one. These contributions. Am I audible, please?
Yes, you're audible. Please move on to the next question, sir. Thank you.
Okay. So 152. So for 152, a 57-year-old man with history of hypertension is admitted to the hospital with pulmonary embolism after having sudden onset of chest discomfort. His blood pressure is 132/62 millimeter of mercury. Heart rate is 85 beats per minute, and oxygen saturation is 95 on room air. Echo reveals normal right heart size and function, and the cardiac troponin I is undetectable. Lower extremity Doppler ultrasound reveals extensive deep venous thrombosis from the right femoral popliteal vein. The patient is started on low molecular weight heparin and concomitant warfarin. On rounds the following day, he asked if insertion of an inferior vena cava would be appropriate. So what is the most appropriate answer? So I think before we attempt the question, I checked up the indications for IVC filter. So it's said to be indicated for patients who have pulmonary embolism in a number of conditions. So for a patient who has a pulmonary embolism but has contraindication to anticoagulation, anything that will be a contraindication, you're supposed to anticoagulate, but we can't anticoagulate the patient due to very strong absolute contraindication. Then also failure of anticoagulation for somebody that has been on anticoagulant and keeps having showers, causing pulmonary embolism, recurrent pulmonary embolism, despite being on anticoagulation. They also qualify to have a IVC filter. Then complication resulting from anticoagulation. Okay, if there are complications resulting from anticoagulating the patient, or progression of the deep venous thrombosis despite adequate anticoagulation. So this kind of patient will actually require to have an IVC in situ. Okay, so it is said that there are absolute contraindications. Absolute indications to actually put IVC filter. So patient with a pulmonary embolism with high risk of recurrent embolism due to poor compliance with anticoagulant use. Patient that maybe for reasons best known to them, I think, that will not be compliant with the use of anticoagulant, they will also qualify. Patient with a limited cardiopulmonary reserve also qualify to have a filter. Large free floating proximal deep venous thrombosis also qualifies to have filter. And then patients at high risk of a complication of anticoagulant, like I said, use, and cancer associated with venous thromboembolism qualify. So there are also relative indications, but they said that the relative indications are spare, it's difficult to actually lay a stronghold on a relative indication. And this is said to be due to lack of enough randomized control trial in that regard. However, the relative indication for giving a patient IV filter will depend on the physician's judgment. Okay, so there are no absolute contraindications to giving any patient a filter. However, the relative contraindication for patient with severe uncorrectable coagulopathy, you may not want to go ahead to do that if the bleeding risk in the patient is so much, or if patient has a bacteremia. Okay, we won't want to go ahead and put a filter. So going back to the question now, so the patient is asking if he's qualified to have a filter. So one, they didn't give us information about the patient having any bleeding risk yet in the information that we were given, and it wasn't like a patient has been on anticoagulant that has not worked. Okay, that would have actually qualified the patient to have a filter, or any complication resulting from anticoagulation. So we don't have those information there. So maybe I should start from E and we'll go up, because when I was going through the answers, I had a few issues. The textbook picked A, which seems logical. but the way B was framed was a little bit confusing. So let me start from E. So E says, yes, given your age and gender, we will schedule you for an IVC filter insertion. So age, gender doesn't qualify anyone to have an IVC. It has to do with the bleeding risk the patient has. Then this said, yes, given the presence of residual lower extremity thrombus, we will schedule you for IVC filter insertion, which is not also part of the criteria. Then C said we'll need to get back to review your images and see how large your pulmonary embolus clot burden is before deciding whether an IVC filter is appropriate for you or not. So it has nothing to do literally with how big it is, as it were. So between A and B said no. Okay, this patient is not qualified. We have no in A and no in B also. So B said no. There are currently no indications for IVC filter placement in the setting of deep venous thrombosis or pulmonary embolism. So then A said, no, you will not benefit from IVC filter at this point, which I agree with. But the B was a bit confusing and said, no, there are currently no indications for IVC filter in the setting of DVT or pulmonary embolism. So why that was a bit confusing was, but I'm looking at them not how do I put it now? They said there's no indication in the setting of DVT or pulmonary embolism, but there's indication if there is a bleeding abnormality, which we're not told. It was a little bit confusing somehow, but I think the A sounds reasonable because patient doesn't have any bleeding challenge, or patient was not placed on the anticoagulant that didn't work ab initio, and patient doesn't have maybe malignancy and the rest of them like that. So I think it is a bit reasonable. I don't know if there are contributions or clarifications or additions. Thank you. These contributions. Can I go ahead? Please, am I audible?
Yes, you are audible.
Okay, can I go ahead?
Yes, please go ahead.
Okay, so 153. Mrs. Tupulo is a 45-year-old woman, history of morbid obesity. Weight is 140 kg, and 140 kg. Hypertension, diabetic. She has been in the hospital for 4 days after having open surgical gastric bypass surgery. On post-operative day 4, she experiences sudden breathlessness, tachycardia, hypoxia, and overwhelming sense of impending doom. Urgent chest CT angiography reveals a pseudo pulmonary embolism, and our blood pressure is 70/45, which is hypertensive apparently, and the urine output is poor. 500 millimeter of normal saline are administered intravenously, and she is initiated on the glutamine with a subsequent blood pressure of 82/55. So what is the next most appropriate step? So bearing in mind that the patient just had surgery 4 days earlier, it may not be a good idea to thrombolize this patient because it will make her susceptible to bleeding, okay? And so if you look at option E and D and E, they are thrombolizing agents, and if the patient gets this D and E, it might actually worsen bleeding in her, so they might not be a very good option, okay? Then there's also no indication for, let me leave C for now. There's also no indication for IVC filter in this patient because there's no bleeding risk as it is now. What this patient seems to have is severe pulmonary embolism. Okay, so so the option is between A and C, but to in this state, patient seems to have severe pulmonary embolism with that low blood pressure of 70/40, which had to be up titrated with dobutamine to have to 82/55. So also enoxaparin may not, because the patient does had a surgery and they're looking at the weight of that patient. If they're going to give an enoxaparin that will actually be sufficient to be therapeutic dose, we might be doing a very high quantity of enoxaparin, which could also make the patient susceptible to bleeding. So the rational thing to do, since the patient blood pressure seems to have come up, it might be right to move the patient to surgically remove the clot before the patient's clinical condition worsens. Because we were able to actually have some, even though it wasn't up to 90, but it was a fair improvement in the patient's blood pressure. So doing a surgical embolectomy might be a bit appropriate compared to the other options. Thank you. These contributions.
Dr. Augustine, I think if there are contributions, people
Okay.
back. So just
okay. So 154. A 67-year-old former heavy smoker is post-operative day 4 from an open to bifemoral bypass operation for severe claudication. On routine post-operative CT scan prior to discharge, a pseudoaneurysm is noted just proximal to the aortic origin of the bypass graft. Which of the following best defines pseudoaneurysm? So just before I approach the question, just to talk about aneurysm, basically, aneurysm is a pathologic dilatation of a segment of a blood vessel. So their classification is in 2 ways. So classified as true aneurysm of false or pseudoaneurysm, and the second one, depending on the extent of the aneurysm, it can be classified also as a fusiform or circular aneurysm. So for a true aneurysm, it involves all the 3 layers: the intima, the media, and the adventitia. The 3 layers are involved for true aneurysm. However, for a pseudoaneurysm, in which the intima and the media layer are disrupted, and the dilated segment of the aorta is lined usually by the adventitia only. So the inner 2 are out of the way. So the only thing holding forth is the third layer, which is the adventitia for pseudoaneurysm. Okay. Then the other one is the fusiform aneurysm or circular. So the way fusiform is described as a lesion, as it's where that affects the entire circumference of a segment of a vessel, which results in diffuse dilatation. So, which means the whole, from the beginning of a vessel to the end of a particular vessel, you tend to have like a uniform dilatation of the vessel for fusiform aneurysm. However, for circular aneurysm, just a portion, okay? Let's assume we have a vessel the length of a pen, for example, now, and just the middle part alone is dilated, okay? You have that's a portion of the circumference resulting in a outpouching, just like the middle area alone. But however, if for the fusiform, look at the entire pen, a viral, and everything is dilated from top to bottom. Please, 1 minute. Okay, so for fusiform, for fusiform aneurysm, it affects the whole length, as it were, as compared with circular, which just picks out a segment. Okay, so going back to the options, they said the question is which of the following best define pseudoaneurysm? So option A said a focal dilatation of a segment in which the intima and the media are disrupted, and the dilated segment is lined by the adventitia only, which is what I read out earlier on. So for true aneurysm, it should affect the 3 layers, but for pseudoaneurysm, it should affect the first and the middle layer already disrupted, and the only one holding forth is the last layer, which seems to be the right answer. Then B talks about a focal dilatation of a vessel only involving a portion of the circumference. So they're trying to describe circular aneurysm there with the option B. Then C, apparent dilatation of a vessel due to intrinsic narrowing, proximally or distal, to the point of apparent narrowing. I'm not sure this makes too much sense to me. It doesn't fit into any particular classification, whether it is fisiform, circular, true, or just talking about dilatation, whether it's proximal to or distal, as it were, to point of narrowing, which wasn't part of description for aneurysm. Then D talks about dilatation of a vessel, though not to the size necessary to be diagnosed as true aneurysm. For true aneurysm, once the 3 layers are involved, it fits into that diagnosis of true aneurysm. But here, they're talking about dilatation, though not to the size necessary. It has nothing to do with size, basically, for true aneurysm, but that it involves the 3 layers, basically. So I think this is not appropriate. Then option E, the appearance of the aneurysmal dilatation of the vessel on imaging due to the angulation of the artery. Sorry, due to the angulation of the artery and imaging technique. I couldn't really make sense of this statement. However, option A just basically defines what pseudoaneurysm is. Is there any contribution or addition? I take the silence as to go ahead, right?
Yes,
So
sir.
155. Okay. So for 155, which of the following factors associated with elevated risk of the development of aortic aneurysm, except so the factors associated with developing an aneurysm. So increasing age is a risk factor. Cigarette smoking is also another risk factor. Hypercholesterolemia is a risk factor. Male sex is a risk factor. Hypertension is a risk factor. Use of stimulants like cocaine is also another risk factor. And we also have genetic risk factors like the Ehlers-Danlos syndrome, Marfan syndrome, Turner syndrome, and the rest of them like that. Those diet syndrome. So the obvious option out there is the female sex. So aging is a risk factor. Cigarette smoking is a risk factor. Elevated cholesterol is a risk factor. Hypertension is a risk factor, and male sex instead of female sex. So I think the odd one here is the female sex. I don't know if there are contributions before going to 156. Okay, so I take that as a permission to go ahead. So
Yes,
for
please.
one, okay, so for 156, it seems like a continuation of 155. So you are seeing Mr. Walker in the clinic for follow-up. Is a 22-year-old man with a familiar history of a sudden death and atrial aneurysm. He's quite tall with widely spaced eyes. Okay, that's what's it called again? Telorism, hypertelorism, and a bifid uvula. So on his first visit, you ordered a transthoracic echo to investigate a diastolic murmur, and then note an aortic dilatation aneurysm of 4.9 cm. He most likely has mutation of which of the following genes. Okay, so fibrillin 1 is associated with Marfan syndrome. This SM83 is referred to as actin filament mutation, which is associated with a type of familiar thoracic aortic aneurysm. Okay, then smooth muscle specific alpha actin is also another variant of familiar thoracic aortic aneurysm. And then so TGF, let me leave TGF now. So type 3 procollagen is associated with Ehlers-Danlos syndrome. However, for the TGF, it's associated with this law is, I hope I'm right with the pronounce. Second one I want to pronounce now, diet syndrome. Diet as in diet then with a Z at the end of it. So Lois diet syndrome. So it's associated with mutation of a transformation growth factor, and also goes ahead to affect two receptors, transformation growth factor BR1 and then BR2 receptors are affected in them. So why does the patient fit well into Lewis-Dietz syndrome? It's okay. Before I go to the clinical features, it's an autosomic dominant syndrome, and associated with a marked aneurysm of the aorta, and associated also with sudden dissection of aorta. So for the clinical features, they have this widely spaced eyes, which is hypertelorism, okay, as stated in the question, and they tend to have a wide or split uvula. There's aneurysm of the aortic root in them. They also tend to have abnormally long limbs and fingers, like the what's it called now, Marfan syndrome patients who usually have. They also have this what we call dura ectasia. Okay, for dura ectasia, it's the gradual stretching or weakening of the dura mater that can cause abdominal or leg pain in those group of patients. They also tend to have strabismus, club foot. They could also have scoliosis or kyphosis. They could have either of a pectus carinatum or excavatum, and then lastly, they also tend to have a bicuspid aortic valve. But what stands them out is the hypertelorism, widening or splitting of the uvula in them seems to be a bit more classical in this group of patients. So the right answer is a TGF beta receptor. So I wouldn't know if there are other contributions. So the one, okay, I think there's a response.
Sorry, sir. Dr. Odonye, the one you talked about now, is that the GENTS criteria that you're talking about?
Sorry, I take that again. I lost you a few seconds. Say the last one I talked about.
Yes, you were giving some criteria, pectus exacerbatum, Dr. ectasia. Was it the GENTS criteria you're trying to talk about?
No, so the clinical features. Okay, clinical features you have with the Lewis-Dietz syndrome. So they tend to have hypertelorism where you have wide spaced eyes. They also have a split or wide uvula, aneurysm of the aortic root. Okay, they also tend to have long limbs, like patient with Marfan syndrome, dura ectasia, strabismus. Some of them could have club foot, scoliosis, kyphosis, either of excavatum or carinatum. They could have either of the two. And lastly, bicuspid aortic valve. Maybe you possibly find that on the.
Okay, thank you so much, sir.
Okay. Then 157, which of the following patients with aortic dissection or hematoma is best managed without surgical therapy? Okay, I think looking at this Stanford classification now, I think at the left subclavian, I hope I'm right, is the borderline for A, and everything below that is for B. So for A, whenever a patient has Stanford A, needs a surgical intervention. But for B, usually use medical therapy. But there are instances whereby the medical therapy might not suffice for Stanford B. And then when you have the dissection affecting major branches, okay, so you might need to have a surgical intervention, or you have impending rupture or continued pain. You also need to consider surgical intervention. So looking at the options, A, patient that will be best managed without surgical therapy. A, 45-year-old female with a dissection involving the aorta distal to the great vessel origin, but cephalad to renal arteries. This seems to be a good option, but let's look at B, C, D, and E. For B, a 74-year-old male with dissection involving the root of the aorta. So we all know anything involving the root, that ascending part, in surgical intervention. A 58-year-old male with aortic dissection, 78-year-old a 58-year-old with aortic dissection involving the distal aorta and bilateral renal arteries. Like I said, there are distal, the Stanford B that will require surgical intervention when they affect major branches. So in this instance, it's not just one branch, both branches to the kidneys are affected, the bilateral renal arteries. So we need a surgical intervention in this instance. Then D, a 67-year-old male with an intramural hematoma within the aortic root, still the aortic root. So you might need a surgical intervention, okay, for the aortic root. Then all of the above patients require surgical management for the aortic disease. Absolutely not all of them. A does not require. So A seems to be the first patient that will fit for medical therapy. Any contribution, please? I take that as a permission to go ahead. Okay, so 158, a 32-year-old woman is seen in the emergency department for acute shortness of breath, and the helical CT shows no evidence of pulmonary embolism, but incidental note is made of dilatation of the ascending aorta of about to 4.3 centimeters. So all of the following are associated with this finding, except giant cell arteritis, rheumatoid arthritis, syphilis, and then Takayasu are associated with dilatation of the root of the aorta. I think the obvious answer here is SLE. Not sure, even when we have all those conditions, I think this the what's called now the renal, hematological, neuro, all those subparts of SLE. There's none of them that has dilatation of the aorta, so it seems to be the odd answer out of what we have here. So just to make it a bit fast, I think that one seems easy, but if there are contributions, please. Yeah, and the additions. Okay, so 159. So for 159, Mr. Tomazili is a 75-year-old man with diabetes mellitus and hypertension. Despite continued counseling, he has been unable to stop smoking imported unfiltered cigarettes. So at your visit today, he complained of burning pain in his bilateral calves, and with ambulation. It typically occurs after about 2 50 blocks of walking on flat ground, and then improves with rest. He has also noted some aching calf pain during the night that improves when he sits on the side of the bed. Which of the following is likely true for Mr. Tomazelli? So one said it's likely has a critical to iliac arterial stenosis. It's a bit difficult to say patient has critical stenosis if we've not assessed the patient by doing the ankle brachial index. So if it's less than 0.9, it's said to be mild. If it's about 0.4 to 0.9, is moderate, and less than 0.4 is severe. And for the non-compressible one, when you have it more than 1.3, it's non-compressible. So we're not given so much information. The only thing we have is just the clinical features. But we need to examine to be sure if it's actually critical or otherwise. So B, the amplitude of his pulse volume contour will be sharp and spiked. Not sure about the option. Let me go to C. The most likely etiology of the symptoms is femoral arterial fibromuscular dysplasia. So I don't think this will be right, because most of the time you tend to find the FMD, fibromuscular dysplasia, in women and not in men usually. Then D, the next most reasonable diagnostic test is the MRA, which is not. It has to be ankle brachial index for us to give a lot of information on how to stage how severe the peripheral arterial disease is. Then E, the ratio of systolic blood pressure in his ankle versus brachial artery is less likely than 0.9. So that seems true. If it's less than 0.9, we're sure he has peripheral arterial disease. However, the exact value will help us to know if it is mild, if it's moderate, or if it's critical. So it seems to be the best option here. So I think I'll go with option E. Option E seems to be the best option. Yeah. So I don't know if there are contributions, additions. Any contribution, please? Okay. So 160. So the patient described in the above 159 is diagnosed with symptomatic peripheral arterial disease with bilateral ankle indices of 0.2, which makes it a mild form of PAD. He asks about his prognosis and then what the next step in treatment will be, and then which of the following statement regarding his prognosis and treatment therapy is true. So for A, we have anticoagulation with warfarin is superior to antiplatelet agents in preventing adverse cardiovascular events in patients with PAD. This is not true. From what I read, some of the papers I read said that anticoagulation is not anticoagulation with warfarin is not superior to antiplatelet as far as peripheral arterial disease is concerned. Then B say adrenergic beta blockers have been shown to worsen limb ischemia and should not be used in them. So I'm not sure. Let me leave B for now. Then C, it should exercise daily, walking to the point of maximal claudication before stopping to rest and allowing the symptoms to relieve him. Then D, the greatest risk to morbidity and mortality over the ensuing 5 years is progression of critical limb ischemia. Then E, vasodilators are first line for symptomatic peripheral arterial disease. Starting from the E, I think I said they're not a first line for managing peripheral arterial disease for E. Then let me go back to B. Beta adrenergic blockers have been shown to worsen limb ischemia and should not be used in peripheral arterial disease. What? I'm not sure about that. But I read something about them. This C and D is a bit confusing. C, I read something about why they have the disease that they're encouraged to move around, and then when the pain kicks in, then they're advised to stop and take some moment of rest. But this is talking about prognosis. Though the answer they picked is D, I can't really explain it well. I didn't have enough time for this particular last one to check more papers to it. But what they said was D. I can't really explain that so well, but that was what they picked. So I didn't have enough time to tidy up this one very well. I don't know if there are contributions, additions. So what they said is his greatest risk of morbidity and mortality over the ensuing 5 years is progression to clinical limb ischemia. It sounds right, but I can't really explain it with C or D. I can't remember what I read for beta adrenergic. I can't remember that for now. So I will appreciate if there are contributions, additions. Thank you.
So let me just mention that for B, the beta adrenergic blockers, they have not been shown to worsen claudication. Okay, so
Thank
that
you.
means it doesn't add up there.
So that leaves all with C and B. Thank you, sir. That leaves all with C and D. Because I read at some point that they are advised to walk around, and when they have the pain, they are advised to rest. But I didn't have so much time on my hands to properly evaluate C and D variable. But this is the last of my question. I would appreciate if there are little clarifications, someone that could just lead us to having a better understanding of what the answer is. Thank you. So that's my last question, please. I don't know if someone else is ready while we wait for maybe any contribution on the question. Thank you.
Thank you very much, Odoye.
Yes, sir.
Okay,
Oh,
good evening. I'm ready.
all right, Chineme, welcome. Which question are you taking from?
121. Good evening, sir.
Let me go there now. Thank you very much. Right, I think you can go ahead. Thank you.
Okay, it's 124 I'm seeing. Okay, yes, thank you. It's fine now.
I
So
thought you
good
said
evening,
121.
chiefs and colleagues. I'll be taking 120. Yes, it's fine now. It's okay. Hello, sir.
Sorry, it was my network.
Okay,
Thank you.
all right, thank you. So I'll be taking 121 to 130. So ask Mr. Jackson from question 120. Okay, so please go to question 120. I think we need to answer that before 121. Okay, thank you. So Mr. Jackson is undergoing an exercise stress test. You know that as he progresses through his stress test, his myocardium will require more oxygen. How does the normal heart respond to meet its higher oxygen demand? So A, increased myocardial oxygen extraction, near constant coronary blood flow. So basically this does not look correct.
Let me go and stay with Samity.
Then increased oxygen extraction from the ventricular chamber. So I think this one is totally off. Then relative expansion of the diastolic time period, allowing increased coronary flow. So this one too doesn't look correct. Then vasodilatation of epicardial coronary arteries, leading to decreased resistance and increased coronary blood flow. Then option E, vasodilatation of intramyocardial coronary vessels, leading to increased coronary blood flow. So of all the option E looks most correct, because if you have vasodilatation of the myocardial coronary vessel, it would actually lead to better increase in the coronary blood flow to meet the higher oxygen demand that Mr. Jackson needs. So basically the myocardium, it has a high oxygen need and it's actually fixed. So most times if it's going through stressful conditions, I'm doing it. Okay, so basically it has an increase, sorry for the interruption, it has a fixed percentage of blood flow. And so during times of increased stress, it increases the flow to the coronary, the intramyocardial coronary arteries to enable it meet up the oxygen demand. So the best option for this question is option E. I don't know if we have any questions or comments. Okay. I didn't check that up very well because that was not part of my question, but I think it is the most appropriate. Then for question 121, as Mr. Jackson continues on his exercise stress test, he begins to complain of a pressure-like chest pain. Okay. You suspect that he's experiencing angina due to a partially occluded coronary artery. So if you were able to immediately analyze the biochemical changes occurring in his ischemic myocardium, you would note all of the following except. So this basically feels the man is having angina during a stress test. So, and then we're asked if we analyze his biochemical parameters, what would we see in his ischemic myocardium? So an increase in cytosolic calcium, that's true because of course cytosolic calcium will be needed during that period of contractions. And then an increase in intracellular pH. This falls because usually when somebody has an ischemic myocardium, usually the heart uses the fatty acids for production of its own energy and then sometimes glucose. But the main production of energy is the beta oxidation from fatty acids. So when this is interrupted, it kind of like switches from an aerobic to an anaerobic pathway. So you have lactate production. So with lactate production, the pH tends to fall, not increase. So an increase in intracellular pH would be incorrect. Then a shift from aerobic to anaerobic metabolism is correct because of the ischemic process. Then depletion of myocardial stores of high energy phosphates. Of course, high energy phosphate refers to ATP, creatine phosphates that are used for energy. So that will also be reduced in the patient because of the ischemic myocardium. Then leakage of potassium from myocytes. So during this ischemia, some of the cells have been noted to have like dysfunction in their voltage-gated channels. So there might be leakage of potassium and increased influx of sodium. So from these options, the except option will be an increase in the intracellular pH because of the production of lactate. So I don't know if we have any questions or comments. Okay, so question 122. Which of the following sites is an unusual anatomic location for anginal pain radiation? So A, back, so that's correct. The interscapular region, that's true. Root of the neck, that's true. The teeth, that's also true. And the trapezius muscle. The trapezius muscle, usually the pain of angina actually doesn't radiate to the trapezius muscle. The trapezius muscle is that kind of triangular muscle. It looks like a trapezius at the back. At the back, just in between, lower down, close to the neck, and lower down, just in between or above the scapular region. So the pain of angina doesn't go there. It's actually the pain of pericarditis that goes towards the trapezius muscle. And then it's been noted that the pain of angina does not go above the mandible. So usually it's around the jaw, the teeth, just the mandibular area. It doesn't go to the maxillary area or above. Usually it doesn't go down below the umbilicus. So actually anginal pain can be epigastric, especially in those atypical ones. It can also go to the epigastrium. So the right option is the trapezius muscle, is an unusual site for anginal pain. Okay, so question 123, it says Miss Wilson is a 66-year-old postmenopausal U.S. postal employee. While walking her mail route over the past 9 months, she has routinely experienced chest pressure and dyspnea while climbing a certain steep hill. The pressure resolves when she rests for about 3 minutes. She has not missed any walk due to these symptoms. You suspect she's experiencing angina. What term and Canadian Cardiovascular Society functional class of angina is appropriate to describe her symptoms? So the Canadian Cardiovascular Society functional class of angina, we have class 1, which is angina with strenuous exertion. So when you have symptoms after or during a strenuous activity, so that means you're in class 1. Then angina with moderate exertion like climbing a hill, maybe doing some rapid movements, climbing greater than 1 flight of stairs, you have anginal pain, you're in class 2. Then class 3 is angina with mild exertion. That's normal activities, brings on the pain. Then class 4 is anginal pain at rest. Okay. So now, based on this classification, this patient, she just experiences some discomfort while climbing a steep hill. Okay, and it resolves with rest after about 3 minutes, and it doesn't limit her daily activity. She has never missed walk. So that to put her at steep hill should be moderate exertion. So option A, stable angina, CCS class 1. So that will be false because her pain is not on strenuous activities. Then B, stable angina, CCS class 2. That's true. Climbing a steep hill is under moderate exertion. Then stable angina, CCS class 3. Class 3, that's mild exertion. No. Climbing a steep hill, going to walk, I think that's more than mild exertion. Then class 4, at rest. No. At rest, her symptoms resolve, so that's off. And then unstable angina, the symptoms resolve at rest, so that is off. So the answer is B. I don't know if you have questions, comments, or contributions. If not, we'll move to question 124. So a 50-year-old accountant with a history of cigarette use completed an exercise treadmill ECG stress test. So during his test, sites off.
Sorry about that. I think it was his network.
Okay, okay.
Yes. Dr. Christy, please, can you help us share the question? Or who else can help us share? Dr. Etuli did mention that his network was not really stable. Thank you very
Sorry
much.
about again.
Yes.
Okay.
Sir. Thank you, sir.
Okay, thank you, sir. Okay, so question 124. A 50-year-old accountant with a history of cigarette use completed an exercise treadmill ECG stress test. During his test, he developed upsloping ST depressions in lead 2, 3, and AVF. His peak heart rate achieved was 130 beats per minute. His blood pressure increased from 120/80 to 155/95. What is the appropriate interpretation of this stress test? So if we remember the teachings on the stress testing, so first of all, they said during the test, he developed upsloping of the ST depression, upsloping ST depression. So that one is totally out because it's one of the normal features in exercise. So when someone is exercising, the stress exercise test, the ECG finding of upsloping is a normal finding, so it doesn't show ischemia. So basically, the stress test has three basic parameters you'll be looking at. One, you'll be looking at hemodynamic compromise. So you'll be checking all the blood pressure. Is the blood pressure increasing? The systolic blood pressure increasing? Is the diastolic reducing? Is the patient having up to less than 12 beats per minute drop in the heart rate after the whole stress exercise? So you're just looking at the those parameters. That's one. And secondly, you'll be looking at the clinical features during the time of the stress test. So did the patient develop anginal symptoms? Did the patient have any, or maybe got tired, had reduced perfusion, signs of reduced perfusion and all of that? So you'll be looking at the clinical things also that occurred during the stress time. And then finally, you'll be looking at the ECG. So the ECG that is that counts is the ECG of downsloping, that's the depression, or flattening. Okay, so that's greater than 0.1 millivolt, or one small square when you're taking it at 60 to 80 millimeters off the J point. So if you have that, that's what is significant. So now this patient is showing an ECG that is showing an upsloping. So that's a normal finding. So this wouldn't count. Now his peak heart rate achieved was 130 beats per minute. So that's part of your hemodynamic assessment. You have to assess if this patient was properly stressed to be able to bring on an ischemia. Because if the patient was not properly stressed, did not meet the 85% of the maximal heart rate, it's not going to actually stress the heart enough to show if that patient has an ischemic event or not. So if you're saying 220 minus 130, then times 85 over 100, that's taking 85%. That means the patient should get up to 144 to say that the patient had a proper stress for an ischemic event. So he didn't have that. His maximum heart rate achieved was 130. Then now his blood pressure increased from 120 over 80 to 155 over 95. So this is appropriate for the systolic increase, because you're supposed to have systolic increase in the systolic blood pressure as the patient exercises. But invariably too, you're supposed to have a reduction in the diastolic pressure as the patient exercises. So the patient has appropriate systolic response during the exercise. Okay, so now in interpreting the stress test, a negative stress test, inappropriate hypertensive response to exercise. So this is false. You can't say if it's negative or positive, because the patient was not maximally stressed for you to be able to determine that. And now negative stress test, non-specific ST changes. That one is totally off. Then non-diagnostic stress test, normal blood pressure response. So this is good because it's non-diagnostic, because actually the patient didn't get to the heart rate to elicit an ischemic event. And then of course the patient had appropriate blood pressure response. There was an increase in the blood pressure during the test. Now positive stress test is false because it's an upsloping ST depression. Okay, inappropriate hypertensive response to exercise, this false, it increased. The blood pressure increased. And the positive stress test, this is also false. It's not positive. And then normal blood pressure response, that's false. So the most appropriate answer will be the C option. I don't know if we have any contribution or question. Okay, so question 125. A 70-year-old woman presents to the emergency department with 3 hours of acute shortness of breath and crushing substernal chest pressure. Her ECG shows 1 millimeter ST depression in leads 2, 3, and AVF without any ST elevation. So it's like an end-STEMI. Initial serum troponin level is mildly elevated. You suspect that she's having an end-STEMI. All of the following are causes of end-STEMI except, so basically end-STEMI is as the commonest causes as a result of mismatch. So I would say maybe type 2 MI, a result of mismatch between the oxygen demand and then the perfusion. And usually as a result of partial occlusion of the affected vessel. Okay, with total occlusion, you have the ST segment elevation. So the options of coronary vasospasm, yes, coronary vasospasm, or they say dynamic changes in the blood flow, even if we know it springs metal, but it has also been seen as one of the pathogenesis for end STEMI. Then increased myocardial oxygen demand produced by system mismatch. So that's true. That's one of the pathophysiology behind end STEMI. Then microvascular endothelial dysfunction has no infarction. I think basically we used to see it when we have all those ANOCA, INOCA, they have microvascular endothelial dysfunction. So it's not a cause of a myocardial infarction, whether STEMI or STEMI, okay? Then D, partially occluding thrombus. Yes, partially occluding thrombus is the cause of an end STEMI, and then progressive coronary arteriosclerosis leading to severe mechanical obstruction. So the except option here will be the microvascular endothelial dysfunction. It has not been shown to be a cause of a myocardial infarction. So I don't know if we have any contribution, comments, or question. No, we'll go to question 126.
Sorry, what about option A, please? Vasospasm.
Coronary vasospasm, yes. Coronary vasospasm falls under dynamic change. So one of the positive changes in the flow of blood that will lead to some form of mismatch for them and can result in an end STEMI. I know commonly we see it with Prince metal angina, but it has also been shown to be one of the issues with patients with end STEMI.
Okay, thank
Hello,
you.
sir. Okay. Okay, so question 126. So Mr. Brand is a 57-year-old hockey team coach with a prior history of hypertension, hyperlipidemia, and tobacco abuse. He presents to the emergency department tonight after experiencing chest discomfort during a practice. He notes that he first began experiencing chest discomfort 3 weeks prior with vigorous exertion during practice. However, over the last week, it has taken less exertion to initiate the discomfort. Tonight, it occurred while he was just sitting on the bench. He describes the discomfort as a pressure radiating to his jaw, typically lasting about 10 minutes. His ECG shows new T wave inversions in lead 1, 2, AVL, V5, and V6 since his last cardiogram 2 years ago at a routine physical examination. So which of the following clinical entities is an appropriate diagnosis for Mr. Brand to ACS? So he has all the features of ACS. So our mind is going, which of the ACS components does he have? So end STEMI, non-ST segment elevation myocardial infarction. So that one is a possibility, so we'll keep that. Then ST segment elevation myocardial infarction. His ECG didn't really show that the elevation in the ST segment is off. He now has discomfort at rest. Okay, and now it occurs both at rest and on exertion. So stable angina is out of it. Then unstable angina is a possibility. Then more information is required before making a diagnosis. So out of all of this, the most appropriate diagnosis is to get more information, meaning that we need to get troponins to be able to differentiate initiate, is he having a non-ST segment elevation MI, or is he having an unstable angina? Because they just said new T wave inversion can be seen in SMI, they can be seen in unstable angina. So what actually separates them is the presence of troponins. So if we have elevated troponins, we'll be going towards STEMI. And if the troponins are normal, we'll stay with unstable angina. So for these patients, we can't really say since no troponin was given. So the most appropriate option will be more information is required before making a diagnosis. So I think option E is the best option. Do we have any comments or questions or contributions? Okay, so question 127. So Mr. Rivera is a 42-year-old man with anuric end-stage renal disease due to DM. Due to recent car trouble, he missed his most recent dialysis appointment and presents to the emergency department with shortness of breath. His heart rate is 105 beats per minute and blood pressure is 185/100 mmHg. He has fine rails in the bilateral lower lung fields and his JVP is elevated. ECG shows sinus tachycardia without ST deviation. Initial troponin I assay returns at 0.14 as against 0.06. What are the next most appropriate therapeutic and diagnostic steps? So A, administer 80 milligrams of IV furosemide, follow serial troponin I values and ECGs. B, administer 80 milligrams of aspirin, refer for pharmacologic nuclear stress testing. I think this one is totally off. C, initial dual antiplatelet therapy and heparin, follow serial troponin 1 values and ECG. The ECG only showed sinus tachycardia. So I think this is not necessary. Then initial dual antiplatelet therapy and heparin, refer for urgent coronary angiography. So this is totally off. Then E, initiate urgent hemodialysis with ultrafiltration for fluid removal, and then follow serial troponin I values and ECG. So basically, I think this patient missed his dialysis. He's currently anuric, so he requires urgent hemodialysis. That's one. Then he came to the emergency department, shortness of breath. So it looks like he has like a hypertensive emergency, blood pressure of 185/100. He has some symptoms, shortness, like an acular ventricular failure, although they said his JVP is also elevated. So the patient is having, I think all the troponin elevation he's having may be from his whole hypertensive emergency heart-related things. So I think the best option for him would be to initiate hemodialysis, and then you can do serial troponins and ECGs to find out if he has any new changes to support any reason for any of this, because the ECG don't just show sinus tachycardia without any ST deviation. So I don't think he needs any of these dual antiplatelets and all of that. So I don't know if anybody has any contribution to this.
Yeah, E makes much sense. Thank you.
Okay. So question 128. A 67-year-old fried chef at the local waffle emporium presents to the emergency department with the sudden onset of crushing substernal chest pain He has a history of hypertension, hyperlipidemia, and erectile dysfunction, for which he takes daily amlodipine, simvastatin, and tadalafil. On your evaluation, his blood pressure is 145/85 millimeters of mercury, and heart rate is 90 beats per minute. His lungs are clear, and JVP is not elevated. There are no murmurs or gallops on cardiac auscultation. He continues to complain of chest discomfort, rating it at 8/10. Initial troponin I results in initial troponin I result is elevated at 0.52 nanogram per dl as against 0.06, so it's elevated, markedly elevated. And ECG reveals 1 millimeter ST depression in the lateral leads, the inferior leads and the lateral leads, okay? All of the following pharmacologic therapy is reasonable to administer except, so basically the patient has end-STEMI because he has elevated troponins, then 1 millimeter ST depression in those leads, okay? So now all of the following pharmacological therapies are reasonable to administer except, so aspirin. So yes, like what I said about the pathophysiology of end-STEMI. So basically you have a thrombus partially obstructing. So giving, so we basically give our antiplatelet, dual antiplatelet therapies, okay, to take care of that part and anticoagulation. Then because majorly they have a mismatch between the myocardial oxygen demand and the perfusion, so we'll tend to relax the heart a bit, so beta blockers will need to come in for them. So aspirin orally is true. You can use aspirin or you can use any of the P2Y12 family. So clopidogrel, fine, it can be used. Heparin, yes, we can use any of the anticoagulants, unfractionated, low molecular weight. Fondaparin, are the direct ones. Any of them can be used. Metoprolol is a better blocker. Yes, it will help with the pathophysiology of taking care of the mismatch by reducing the myocardial oxygen demand. Then nitroglycerin sublingually. Yes, this is actually an anti-anginal medication that can be used, but because this patient is on tadalafil, that will cause vasodilatation. This one also would do another work with vasodilatation, so the patient will go into hypotension. So it's actually contraindicated to use both the phosphodiesterase 5 inhibitors and the vasodilators like nitroglycerin. So two of them cannot be used together. So I think option E will be the except option. So I think this one is straightforward. Okay, so question 129. So Mr. Gilotra is a 57-year-old oil rig worker with a history of hypertension, tobacco abuse, and DM. He presents to the emergency department with 30 minutes of crushing substernal chest pain radiating to the jaw and associated with profuse sweating and shortness of breath. His blood pressure is 115/90 millimeters of mercury. His heart rate is 95 beats per minute. What diagnostic test will provide the most rapid method of altering therapeutic management for Mr. Gilotra? So basically, it looks like Mr. Gilotra is having an ACS, okay, basically an anginal pain, okay, because of the 30 minutes radiating. So we're just trying to look for how would we make the diagnosis rapidly. So 12 lead ECG, good. Coronary CT angio, not good. We have ECG. I think we should start with ECG. Echocardiogram, it won't really tell if he has end-STEMI. It won't be able to differentiate anything. So just show regional wall motion abnormality, but basically not telling us exactly what he has. Then serum creatinine kinase NB, it will take a while before it begins, at least a few minutes to hours before it begins to rise. So then troponin I levels, it will still take time for us to make an altering therapeutic management. So the best option is the 12-lead ECG. We can do it quickly, we can make a diagnosis, and we can offer solution. So I think option A is the answer. I think this one is straightforward. Then question 130. Okay, so you are evaluating a patient with chest pain in the emergency department. So the ECG shows no Q waves or ST segment changes. You wish to know whether the patient is suffering a myocardial infarction. Which of the following biomarkers is a preferred biomarker of myocardial infarction? So this one is straightforward. The answer is troponin I. So I don't think we need to talk too much. So the cardiac specific troponins are T and I, like we all know. So they are preferred over all these ones that are really not specific. So troponin I is the most preferred biomarker that can be used. So thank you. I think that's the end of my own. Are we sleeping? I'm done.
No, we are not sleeping actually. No more, Dr. Chineme. Thank you so much. We are very grateful. Well, I don't know whether Dr. Brown is around now. Or is any other person ready to take his or her part? Dr. Florence, Dr. Okore, Dr. Brown, Dr. Cassidy, Dr. Adedeji. One of them is on the platform. So, Chiefs, we have two choices: to go and sleep now or to push on. So please, I'll need our feedback. Dr. Imalade, what do you think? No, or are people sleeping already so that we can all just go and sleep? Hello, please, am I audible? Dr. Chineme, am I audible?
Yes, so I think that if you look at the nature of the questions, some people are not available. If we decide to take them randomly, we may spend time trying to research the answers to tally with what's in the book and all that. So maybe we can create backups. I mean, those who are on the group today can take extra 10 each. Then tomorrow when we can be very swift so that we don't have this situation happen subsequently.
Yeah, thank you very much, Dr. Frank, for that. Chief Examiner.
I think I agree with him. It's just to create a backup so that we'll finish this thing tomorrow. So again, tomorrow we know we are going to do a long marathon. So it's to create backup, publish it on time, and let everybody get to see it on time. Probably it's remaining about 70 questions now, right?
Yes. That's 70. Okay. Thank you so much, sir, for your counsel. So I think we should just do the distribution right now, because all these people that have it too, they are always in the meeting. We don't know what happened today, so we need to be sure. Dr. Lalo, can we give step 81 to 90?
Sorry, can we stop the recording?
Yeah, I'm not sure that Dr. Precious is close to our system.
I'm here.
Let
Oh,
me,
no.
okay.
Sorry, excuse